Assalamu alaikum everyone. My name is Aylin. I'm a third year medical student.
Hello everyone, my name is Mohamed Abdulrahim. I am a second year medical student, and today we're going to give you guys the Endo Repro OSPE crash course.
We're very excited to give you this PAL. Inshallah, it's going to be as inclusive as it could get. And best of luck on your studies. This PAL is recorded, so we have our contacts here. Please feel free to ask us anything. Inshallah, it's going to be amazing. Yalla, I'm going to start. First of all, I'm going to start with the endocrine portion, which includes everything you guys studied from like the glands to the histology of these specific glands. The first gland that you guys studied was the pituitary gland. This gland is very small and is kind of located in your brain, but it's very important. So what you have to know about this gland is where it's placed and the specific structures it has. Okay, so it's two structures. First is the anterior pituitary, and second is the posterior pituitary. The anterior pituitary is also called the adenohypophysis, and the posterior pituitary is also called the neurohypophysis. Neurohypophysis because it has like more neuronal cells. We see on the histo slides how it has more neurons, okay? Or it has neurons compared to anterior, because anterior doesn't have any neurons, okay? It's in the sphenoid bone, indentation specifically to this called to fit this gland, and this indentation is called the sella. This indentation is part of the sphenoid bone, and this is the sphenoid bone, and it has a sinus. This is called the sphenoid sinus. This infundibulum connects the hypothalamus to the posterior pituitary. It's part of the pituitary gland, but it connects the hypothalamus, which is right here, to the posterior pituitary. And why is it called hypothalamus? This is a fun fact. This is the thalamus. Inshallah, when you guys study neuro, this is called the thalamus. So under it, yani hypo, under, is called the hypothalamus. Okay? So the infundibulum connects the hypothalamus, which is this structure right here, like in brown, to the posterior pituitary. Okay? Next, we have something called the optic chiasm. This structure is very important because it could get compressed because of if the pituitary gland gets larger or something happens to it, it could get compressed. And why is it important? Why do we care about this not getting compressed and this being preserved? Because the fibers that go to your eye or the fibers that are responsible for you seeing, they cross here. And if they don't cross, or if something that damages this optic chiasm, the person or the patient won't be able to see like on their peripherals. For example, يعني you would be able to see like directly, but if you want to see things on your side, you can't see them. So we'll talk about this later, but they lose their temporal vision if something's wrong with the optic chiasm. Okay. Moving on, we have to talk about the hormones that it secretes because it's a gland and it's responsible for hormones. So the anterior pituitary, which is also called the adenohypophysis, like it makes these hormones and it releases them. Okay, and it's very important to differentiate between a gland storing hormones and a gland making these hormones. So the adenohypophysis makes and stores the FSH, LH, TSH, ACTH, prolactin, and growth hormone. Okay. But for the posterior, which is the neurohypophysis, it stores the ADH and oxytocin. It just stores them. It doesn't synthesize them. Where are they synthesized? In the hypothalamus. So they're synthesized in the hypothalamus, and through the infundibulum that we talked about, it's a stalk. They go down and they get stored in the posterior pituitary. So these are the only two hormones that are present there. And when your body needs them, they get secreted from the posterior pituitary or the neurohypophysis, but they're not synthesized in the neurohypophysis. Is this clear? Inshallah, it is. Okay, these are pictures or like the models that you guys have. I'll point out the important structures. This is the pituitary gland, and why can you like no, this is the pituitary gland, not something else? Because it lies above this indentation, which is the sella turcica, and this what we say. This is the sphenoid sinus. Okay. What is this? This is anterior to the pituitary gland. What did we say? Optic chiasm. And anterior to it, yeah, this is the face, so it's anterior, in front of it. And this is the infundibulum, the stalk that connects the hypothalamus, which is number 18 here, to the pituitary gland, okay? This is the same structure here. As you can see, this is the sella turcica, where the pituitary gland, number 11, is sitting inside. And then the 14 is, what's it called? The infundibulum, the stalk يعني. 18 is the hypothalamus and 17 is anterior to it. This is the face of the patient or person, and this is the back of his face. But in front of it is the number 17 is the optic chiasm. And what is this thing in blue? It's basically something called intercavernous sinus, and it surrounds the entire pituitary gland. But here it just shows it's on front, but it surrounds the entire gland. Not very important, but يعني it's just worth a mention. Okay, moving on to the blood supply. The blood supply isn't very important in OSPE context. Of course, it's important for your lectures, but for OSPE, just know that there's the superior and inferior hypophyseal arteries. The superior hypophyseal artery supplies the anterior pituitary gland, and the inferior supplies the posterior, yani the neurohypophysis, okay? And what's important in this, why do you have to know this? Because it forms a plexus, and this is how hormones like they get يعني, released, or they go to the pituitary gland and then go to your body through plexuses or capillaries like blood. Okay. Next is the embryo. They might ask you this is like in like a sub question in an OSPE exam, but it's very important to like study the actual lecture. يعني very what's it called? Very broadly, the adenohypophysis, which is the anterior pituitary, comes from the oral ectoderm, which is from the Rathke's pouch. So it's very important to just know, no, it's just Rathke's pouch, okay? And if they ask you, you can just write this and it will be correct. The neurohypophysis, which is the posterior pituitary, is from the neuroectoderm, because as I said, it's like a neuronal gland, so it's from the neuroectoderm, okay? Moving on, we have, as you can see here, this picture I showed you before, but I want to zoom in to the pituitary gland because I want to talk about something that happens here. What did we say this is? This is the optic chiasm. Okay. So if there is a pituitary adenoma, what did we say that is? This is cancer. For example, yani this gland got cancer or adenoma here, and it got bigger, it got enlarged. If this gland gets enlarged, what could it press? What did we say as lies anterior to it? The optic chiasm. So the optic chiasm can get compressed. And why is this very important? Why يعني we have to like think about abnormalities that could happen if the pituitary gland got bigger, because this compression can lead to bitemporal hemianopia. What is bitemporal hemianopia? Patients would see things like these, like this. Notice how they can't see anything from their peripheral or temporal vision because the crossing, don't have to know the exact anatomy of it, inshallah you'll study it, but the crossing of the fibers that are responsible for temporal vision, they happens in the optic chiasm, and if it's compressed and if it's damaged, you get something called bitemporal hemianopia. And I remember when I was first year, Dr. Yaqeen mentioned that these patients really don't know that they have this until they come to the hospital and they say, no, oh, I've been getting into more car accidents, because they can't see their like to their side. A car comes and they don't see it because they can't see to their side. Okay. It's called bitemporal hemianopia. It's very high yield. They likely ask you about this, if not an OSPE and MCQ. So just like know the anatomy, and know if this gets enlarged, it will affect or compress or structures that are related to it, and most evidently and most importantly, the optic chiasm. Okay. Okay, moving on to the histology. This was it for the anatomy and for things that you took in dry lab. For the histology, this is the gland. This is how it looks like. And as you can see like there's kind of two distinctive like places here. This one is called the pars distalis, and it's part of the adenohypophysis or the anterior pituitary. And as you can see, it's kind of bigger and more like darker. It's more pink, more purple. This one is the pars nervosa, and from its name, nervous tissue nervosa, this is the neurohypophysis, the posterior pituitary. And this part in yellow here that I highlighted is called the pars intermedia. This is a part of the adenohypophysis, okay? So the pars distalis, which is darker. Why is it darker? Because it's more like glandular, it has more cells, it's very cellular. It's part of the adenohypophysis because we said that it synthesizes these hormones that we talked about, and it secretes them from there. It synthesizes these hormones. You need these cells to synthesize these hormones. It's very cellular, it's darker, it's more purple, more pink, okay? The intermedia is just separating the anterior from the posterior pituitary. Nothing very specific about it. Just know it's in the middle, and you can kind of like see how it's like separates them, and it's kind of distinct. For the pars nervosa, it's lighter because it has like axons and it's more neural, okay? This picture is a cross-section from the pars distalis. And what did we say the pars distalis is? The adenohypophysis. It's the anterior pituitary. And as you can see, it's a cross-section from here. Very cellular. What are all these cells and how can you differentiate between these cells? So first of all, let's talk about the acidophils. They're kind of like the hot pink cells, okay? They're more eosinophilic. They're very pink, they're very bright. And these cells, let me see here. These cells, they synthesize growth hormone and prolactin, okay? And for the basophils, which are more blue from the name, يعني it's more blue or more, يعني you can say purple. You can kind of see, for example, there's this one, compare this one to this one. This is more pink, يعني more like it looks brighter. This one's an acidophil. But for the purple one or the more bluish one, it's a basophil, and they synthesize FSH, LH, TSH, and ACTH. Okay, and then you have chromophobes here. They're light, يعني they don't really get stained. They're clear. I don't think they're gonna ask you about this because I searched this because I was curious. I'm like, what do these cells do? They do nothing. They're kind of like resting cells, and they're called chromophobes. For the chromophils, it's both the acidophils and basophils. And as you can see here, C is just capillaries. There's capillaries everywhere. Yani there's always blood supply to everything in your body. So to revise, the more like pinkish or reddish hot pink cells, they're acidophils, and they synthesize growth hormone and prolactin. Basophils are more purple, more blue. They synthesize FSH, LH, TSH, and ACTH, okay? And then the chromophobes are clear, or they don't really have a specific function, فيعني kind of ignore them. Moving on, this is a cross section to show you how distinct these three like places are. This is more cellular. This has acidophils, basophils. As you can see here, they're hot pink, they're purple. This one's more like lighter, more pink, because this one's we're gonna talk about it now. It has like axons, and it's just in the middle. Nothing very specific about it. Yeah, you can kind of ignore its existence. Okay. For the pars nervosa, it's the neurohypophysis, and what did we say? It stores ADH and oxytocin. Okay, it doesn't synthesize anything. It's a kind. It has axons though. Where are the axons? Do you what do you think it is? Is it C? Do you think this is an axon, the circle? No, it's not B because this looks like a cell. It doesn't really look like axonal bodies. It's A. A, they're unmyelinated axons. But I really don't think they're gonna ask something that looks kind of like it's an axon. B, what is B? It's something called pituocytes. You guys took, I think, in foundation about glial cells. They're cells that are found in the nervous system, and they're called pituocytes because they're found in the pituitary gland. What's their function? They're basically like helper cells. They help, they support. If something goes wrong, they kind of like they're structural helper cells. Okay, they're purple, yani they're the ones with the purple nuclei. For C, this is the most important and most high yield. And if they want to ask you about this slide, they're gonna ask you about C. It kind of looks like it's circular. Even this one, it's like circular and kind of like obnoxious. These are called herring bodies. And what are these bodies? What's the main function of the posterior pituitary or the neurohypophysis? To store ADH and oxytocin. So these herring bodies, as you can see here, this one and this one, they store these hormones, and when your body needs them, يعني they get released from the hormones. And come on, I read something about the pituitary. It kind of helps in like the signaling, oh, the body needs these hormones. It's a helper cell. Just think of it as a helper cell in the nervous system. So this is C, and D is capillaries. I told you there's capillaries everywhere. This is just where the blood's flowing. Okay. This is it for the pars nervosa, and the most important thing is the herring bodies, okay? They have ADH and oxytocin. They contain, they store, they don't synthesize. Okay, this is another picture from pars nervosa that I found in case they want to get you the specific slide. These are axons, these like linings. Capillary purple cells are pituocytes, they're not labeled, but they're pituocytes. And these kind of like big circle, they look different color. They're herring bodies, and what do? They store ADH and oxytocin. So in this picture here, what do you think the black cells are? I mean, black cells, the black like arrows. What are they? They're kind of like circular, different color. They're the herring bodies. And what did we say they do? They store ADH and oxytocin. For the red arrows, they're purple. Yeah, the purple cells, they're the pituocytes, they're glial cells, and the blue arrows are capillaries. Yeah, just blood. Okay, that's it for the pituitary gland. Now let's move on to the thyroid gland. And sorry, I don't have Camera Premium. A thyroid gland is a very tiny gland. It's found here in your neck, and it has three lobes. It has the right lobe, the left lobe, and a lobe that's not found in everyone. It's called the pyramidal lobe. This lobe is yani, very important because sometimes when they're doing surgery to the neck, they don't realize or know that this patient is part of the people that have this specific lobe, and they might injure it, and it could cause a lot of bleeding. So you have to always like think about, this patient might have a lobe in the middle, and this is the isthmus, which is in the middle of the right and left lobe. Okay, and this is the hyoid bone, this is the thyroid cartilage, and this is the cricoid cartilage. And this is important because there's certain muscles and ligaments that are attached there. Okay, this is the thyroid gland. Okay, moving on. The reason why I put this, I don't know if you guys took this, I don't think so, but the reason why I put it is because I want to explain something specific, which is the how the muscles are attached. What did we say this is? The bone and up. It's a floating bone. It's called the hyoid bone, okay? What is this? The bigger cartilage, it's the thyroid cartilage. And the one down, 18, the smaller cartilage, it's the cricoid cartilage. Why is this important? Because muscles attach and insert there, and they get their names yani, from the cartilage. So what is this muscle labeled 15? Hyoid bone and thyroid cartilage. What do we call this muscle? Thyrohyoid muscle. Thyrohyoid muscle. Okay. For number 16, what is this muscle? It's thyroid cartilage and cricoid cartilage. So what is it called? Cricothyroid muscle. This is the cricothyroid muscle. So yeah, that's it. That's the only thing I want to mention in this specific picture. These are the muscles once again, but in another picture to show you. And the most important thing that you guys have to note here is that this, it's not labeled, but this is a sternocleidomastoid, okay? It lies on top of this muscle labeled in green. This muscle labeled in green is called the omohyoid, okay? Because it's from the hyoid bone and it's going to, I don't know where it's going, honestly, but it's from the hyoid bone. And why did I mention this? Because it has two bellies now. Why? Because it's yani, covered by a muscle. But this is the superior belly of the omohyoid. This is the inferior belly of the omohyoid. And to examine or to see the entire muscle, you have to remove the sternocleidomastoid, and it would look something like this, okay? The muscle in blue, what is the muscle in blue? It's from the hyoid bone once again, and it's attaching to sternum. So what do we call it? Sternohyoid muscle. Sternohyoid muscle. The muscle in red, sternum, and then thyroid. It's going to thyroid. What do we call it? Sternothyroid muscle. The muscle in blue is hyoid and thyroid, so thyrohyoid muscle. Thyrohyoid muscle. Okay. Here's like a picture from your wet lab. This is the patient's head. This is the orientation. This is the patient's head. This is the patient's body. This is their neck, and they went through the skin, the fatty layers, and they accessed these muscles. So what is this muscle? The sternocleidomastoid. And why do you want to remove it? To examine which muscle? The omohyoid muscle. When you remove it, you see that there's the inferior belly of the omohyoid muscle and the superior belly of the omohyoid muscle. And when it was closed, you can only see the superior belly. You can't see the inferior belly because it's like yeah, closing it, and you can't really see it. This is the sternothyroid. It goes from the sternum. This is the sternum here, and to the thyroid cartilage. And this is the what's it called? Sternohyoid. It's going from the sternum to the hyoid. Where's the hyoid? Oh, this here's the hyoid bone, and this is why it's called that. I don't think they're gonna get you a picture. And if they were to ask you about this, they're gonna get you a cadaver, and it would be 100% more clear than this. Okay, this is a concept that was very tricky even to me doing these slides. I remember not knowing how to study this or not knowing the exact يعني details. So I tried my best to get pictures that kind of explain this. In the thyroid, there's capsules. What are capsules? يعني they cover the thyroid. There's a true and a fake capsule. The true capsule is the capsule يعني directly on the thyroid itself. The capsule of thyroid gland. It's like lining it very perfectly. And then there's a capsule which is called the pretracheal fascia. Yani this capsule, it doesn't just lie the thyroid, it lies a lot of other muscles that I don't think you guys have to know. It's not high yield or important at all. This pretracheal fascia, it lies the thyroid, what's it called, thyroid gland. This is called the fake capsule, okay? And this capsule is important when you're swallowing. Yani you don't want your gland to be stuck. When you're swallowing, it's moving. And what allows this gland to move? The pretracheal fascia, okay? Here you can see purple is the pretracheal layer or fascia. It lies, this is the thyroid gland in pink. It lies the thyroid gland, and after it is the investing layer. These are all layers of the deep fascia. I don't think it's important. I just wanted to mention that there's a fake and a true, what's it called? Fascia or true layer, okay? Moving on to the blood supply, there's three main arteries that I want you guys to remember. The most important one, or like the most, يعني, not actually it's not the most important one, they're all important. The superior thyroid artery. The superior thyroid artery supplies the superior aspect of the thyroid gland. Where does it come from? From the external carotid artery. And the external carotid artery, it comes from the common carotid artery. So the external carotid artery gives the superior thyroid artery, and it's up. Please remember that this artery comes from up, okay? And it supplies the upper pole of the thyroid, يعني obviously because it's coming from up. From inferiorly, what's coming inferiorly? The inferior thyroid artery. This inferior thyroid artery comes from the thyrocervical trunk. Where does this thyrocervical trunk come from? From the subclavian artery, okay? And the subclavians from the brachiocephalic, but يعني you don't have to know the entire cascade, يعني all this goes to the heart, يعني obviously it does. Anyway, the inferior thyroid artery comes from down, and it's from the thyrocervical trunk, or you can say from the subclavian artery. This artery supplies the lower pole of the thyroid, and it comes from down. Remember that it comes from down. And there's a third artery which is called thyroid emo artery. This one's like an anomaly, and not everyone has it. So there's nothing specific you have to know about it. Just know that it exists in some people. Okay. Moving on, this is just يعني in text إنه external carotid gives us superior thyroid artery, subclavian thyrocervical trunk, inferior thyroid artery, and thyroid M, which is present in 10% of the population only. Okay, clinical significance. This is very important. This is why I told you to remember that the superior thyroid artery comes from up. As you can see here, it's coming from up from the external carotid artery. It's coming from up. What else comes from up? What else can you find there? The superior laryngeal nerve. Okay, most importantly, يعني, or not most importantly, but they like to ask you or they like to trick you and tell you external laryngeal nerve. And this external laryngeal nerve basically means the superior laryngeal nerve. It's just a branch from it. The superior laryngeal nerve, or the external branch of the superior laryngeal nerve, runs directly with the superior thyroid artery. They're very close, okay? And what's close to the inferior thyroid artery? The recurrent laryngeal nerve. So just know this very well. The superior thyroid artery comes from up, and what runs with it? What's very close to it? يعني إنه what's anatomically very close to it? The external laryngeal nerve or the superior laryngeal nerve. Superior يعني from up, and more specifically, might tell you and the inferior thyroid artery runs with the recurrent laryngeal nerve, okay? Recurrent laryngeal nerve, inferior thyroid artery, they're both coming from down. And the superior thyroid artery is coming from the external laryngeal nerve, okay? Why is this important? Because when surgeons, they want to do a surgery or they want to remove the thyroid gland, they might accidentally damage these structures because they clamp the arteries. فيمكن by accident, they clamp the nerve with it, and that's very terribly, and you have to be very careful and you have to know your anatomy well so you don't damage these nerves, okay? So how do they make sure they don't damage these nerves? This is very anatomically complex and you don't have to know why. But just know, the superior thyroid artery, which lies with what? The external laryngeal nerve. They have to like ligate it or compress it, يعني get hold of it close to the thyroid gland. As you can see here, the superior thyroid artery comes from the external carotid artery. It's coming from here. They wouldn't ligate it here, as you can see from where it's coming out. They would ligate it as close as the thyroid as they can, because when they do that, they prevent damaging the nerve by accident. For they have to ligate it very close to the thyroid gland, away from its origin. Yani it's coming from the external carotid artery, and you don't ligate it there. You ligate it when it's reaching the thyroid gland. This is to prevent damage to what? The external laryngeal nerve, okay? For this inferior thyroid artery, what did we say? It runs with the recurrent laryngeal nerve, and that's a very, very important nerve. To prevent damaging it, they ligate the artery close to the origin, far away from the thyroid gland, okay? And where is the origin? From the thyrocervical trunk. So it's away, yani it's away from the gland. This is yani completely opposite to what they do with the superior thyroid artery. The inferior thyroid artery, they ligate it or they clamp it close to the origin. Yani this artery, it's coming out from here. You ligate it. You don't wait for it to go to the thyroid gland. Okay, this is very important. Just know it as a concept, and it's likely going to be asked about. Thyroidectomy is the removal of the thyroid gland. Okay. So what if this surgeon accidentally damaged one of these nerves? What would happen? So an injury to the external laryngeal nerve results in monotonous voice. And what is monotonous voice? Basically, it would sound like this. Hi, my name is Aylin. I'm a third year medical student, and I'm so excited to give you this spell. It's where you don't have high pitch, low pitch. You sound the exact same. You sound boring. This nerve supplies certain things in your like voice box that help you have like tone. So when you damage it, the person is going to present with a monotonous voice. External laryngeal nerve. What does this pass with? The superior thyroid artery. And where do we ligate the superior thyroid artery? Close to the thyroid gland. Okay. For the recurrent laryngeal nerve, which is more fatal, it's more severe. The person would present with hoarseness. Hoarseness is like they can barely talk. You can barely hear their voice. It sounds like they're breathless. It sounds like they can't speak. And this is damage to the recurrent laryngeal nerve. And where does the recurrent laryngeal nerve go with? It goes with the inferior thyroid artery. And where do we ligate the inferior thyroid artery? Close to the origin. The origin is the thyrocervical trunk. أول ما يطلع the artery you just ligate it. Okay. This is very important. Definitely going to be asked about hoarseness and monotonous. And just know from down is the recurrent inferior. From up is the external or the superior laryngeal nerve. And it runs with the superior laryngeal artery. I hope this makes sense. They're probably going to ask you about this. Very, very high yield. Okay, venous drainage. I don't think it's that high yield, but I'm adding it for just to be inclusive. You have the superior thyroid vein, middle thyroid vein, and inferior thyroid vein. And where do they drain? The superior thyroid vein and the middle thyroid vein, they drain in the internal jugular vein. And the inferior thyroid vein from under, it goes to the left brachiocephalic vein. I think just know this in case they ask you, but I don't think it's that important. Okay, this is a picture that I took from your manual. This is the thyroid gland. This is the trachea. B is the trachea. This is thyroid gland marked by A. What is D? It's coming from up, so it's a superior thyroid artery. It's the left side, yani. Superior thyroid artery. What lies with this artery? The external laryngeal nerve. I'm saying this again because I know a question is gonna come. What is C? It's the left recurrent laryngeal nerve. Where is it coming from? Is it coming from up? No, it's coming from down. So it's the laryngeal nerve. I think if they get you this, they're gonna get you an actual cadaver so you can differentiate if it's an artery or a nerve because you really can't tell here. It just looks like a I don't know. You can't really tell if it's an artery or a nerve. But it's coming from down, so it's what's it called? The recurrent laryngeal nerve, okay? E is the common carotid artery and it splits into the external, and the external gives you the superior thyroid artery. F is the brachiocephalic vein, and I really don't think they're going to ask you about this. They're going to ask you if it's going to be the artery or the what's it called? The nerve. The ones that are that like they run together, superior, inferior, recurrent, external. And yeah, that's all for this picture. Moving on to the histology part of the thyroid gland. So this is what the thyroid gland looks like. This is it zoomed in. As you can see, it's kind of like there's a lot of clusters. What are these clusters? They're like follicles. They're thyroid follicles. There's two parts. There's the stroma and the parenchyma. The stroma is the capsule. What is the capsule? The capsule is always the thing that lines the organ or the structure. The capsule is this. All of this is the capsule and the septa. The septa is like the septum, yani not that important, but just know that this is part of the stroma. For the parenchyma, which is the important part, you have the thyroid follicles. You can see there's a million follicles here. These circles are all follicles, and you have capillaries. They're not shown here, but in the capillaries, I told you they're found everywhere. Okay, let's zoom in to see the follicles because we care about the follicles. We don't care about the other things. This is what it looks like. As you can see, the lining of this pink thing, which is called colloid, is the follicular cells. Okay, and these follicular cells they synthesize colloid. And what is this colloid? It's what's it called? It contains or it releases the thyroid hormones. What are the thyroid hormones? T34. So these hormones are synthesized and stored in like they're synthesized by the follicular cells and they're stored in the colloid. And this colloid yani, is just like a means of storing these thyroid hormones until your body needs them. So it's just like a simple layer of follicular cells that secrete these hormones. They synthesize these hormones and they're stored in the colloid. What are these cells that are like clustered up? It doesn't look like it has something in the middle. It's just clusters. These are parafollicular cells. These parafollicular cells, they secrete calcitonin. And calcitonin is important for regulating your calcium levels. I think you're going to talk about this in detail in MSK. But just know that these clumped up cells, they're the parafollicular cells. They're not follicular cells. Follicular cells are just like a single lining and they secrete the thyroid hormones. Okay? Moving on, there's something called, or not, some follicles might be more active than others. Some follicles might not be active at all. So we have to determine how to know if this specific follicle is active or no. As you can see here, this is colloid and this is the layer lining it. So why is this inactive? Yani, why do you think this is inactive? Because the layer is very thin. And when you see a layer that's extremely thin, flattened squamous cells, you know, and this follicle is not active. Yani, it's not synthesizing these hormones. But for an active cell, as you can see here, it's kind of thicker. It's not, no, stratified. It's still, as you can see here, it's still like a simple layer, but it's thick. It's not flattened, and it's not compressed هيك. فthis is inactive and this is active, okay? Cuboidal cells. يعني they're different than the inactive because the inactive are squamous cells, okay? So the active follicles, they're cuboidal cells and there's less dense colloid. For the inactive follicles, they're flattened squamous cells. And I don't know how to differentiate between dense and less dense colloid, but just know it from the layer and if it's very thin or is it normal cuboidal cells, okay? Okay, this is a question that I found in a past OSPE, and I know I didn't show you this picture, but from the concept, yani from what we studied, what do you think number two and number three are? First of all, this is the thyroid gland, yani, and they're coming from up. What did we say comes from up? The superior thyroid artery and the external laryngeal nerve. And number two is the external laryngeal. No, I showed you the answer. External laryngeal nerve, and number three is the superior thyroid artery. I really doubt they're gonna ask you specific things like these because you can't always differentiate between a nerve and an artery, but just know the nerve is like piercing through the gland. It's يعني they're just piercing through. أما the شو اسمه the artery is like just going lying on it. أما the nerve is what pierces through. Okay, what happens if the superior or external laryngeal nerve is damaged? You get a monotonous voice. If they showed you something من تحت, yeah, for example, this, I'm assuming it's the recurrent laryngeal nerve or the inferior thyroid artery, it would be hoarseness, voice hoarseness. Okay, I hope this is clear. Moving on to the adrenal gland, or glands, because we have two. Let's just look at the anatomy. The glands, the right suprarenal or adrenal gland has a different shape than the left. So the left adrenal gland is shaped is more semilunar. It's shaped like half a moon. Look, it's like circular and as if it's half a moon. The right adrenal gland is more triangular or like that. It looks like a pyramid. Okay. So another thing that I have to mention is that the entire kidney or the adrenal glands, they're surrounded by gyrotous fascia, and it's a fibrous tissue that just surrounds the gland. It's similar to how I said, the thyroid gland has things surrounding it. Same thing here. There's this fascia called gyrotous fascia. It covers the adrenal glands, and just know the different shapes. Yeah, this one's pyramidal, this one's semilunar or like more circular. Because if they get you a cadaver, you might differentiate from the shape. Okay. One more thing, the vein, the superior mesenteric vein, is more on the right side, and the superior mesenteric artery is more on the left side. And just something to note, يعني, just to help you to find, oh, am I on the right side or am I on the left side? Okay, I want to talk about how the adrenal glands, there's adrenal gland, there's a cortex and what's it called? A medulla. The cortex is yani the outermost layer and it has three parts. We're going to talk about them in details in histology, but just know there's a cortex, which is the outermost layer. Yani as you see, this is the cortex, and the medulla is in the middle. Okay, and yeah, that's it. That's what I wanted to mention. For the relations, this is very important, very high yield. As you can see, I mean, as you can know, the adrenal glands, the retroperitoneal organs, they're in the posterior abdominal wall. But there's so many things on top of it. There's so many things yani, that are related to the kidney or more specifically to the adrenal gland. This is a picture that I got, and as you can see here, this is the anterior view. Yani, we didn't remove any of the structures that are in your abdomen to see the kidneys. They're in the back because they're in the posterior abdominal wall. As you can see here, this is the left kidney, and this on top of it is the left adrenal gland, and it's semi-lunar shape. As you can see, it's kind of circular. So what are the relations to the adrenal gland anteriorly? So the what can you see here? What can you find? What are all of these? You have the pancreas, it's on front of it. You have the spleen that's in front of it. You have the stomach. This is again, it's cut. The stomach is cut. If the stomach wasn't cut, you wouldn't be able to see أصلا the kidney. It's in front of it. And then for the right kidney, what's anterior to it? What's the anterior relation to the right kidney? No, sorry. What's the relation to the right kidney? The anterior relation to the right kidney? The inferior inferior vena cava, okay? And the liver. The liver يعني it's like the as you can see they ligated it, they put it up بس إنه if it was like normally in your abdomen it would be on top of the right kidney or the right adrenal gland. So just to recap, the anterior relations to the adrenal glands, the right and left are different because there's different organs يعني, and it's in the posterior abdominal wall. That's why we have a lot of things in front of it. For the right kidney or the right adrenal gland, you have the spleen, stomach, and pancreas, and yeah, that's it. يعني that's the things that you have to know. For the right, what's it called? Right adrenal gland, you have the inferior vena cava and you have the liver, which now is like إنه it's يعني مطلعين لفوق. بس if it's down, if it's under, يعني if it's in its normal position, anatomical position, it would be on top of the adrenal gland. Okay, that's it for the anterior view. For the posterior view, as you can see, as you know, I told you it's in the posterior abdominal wall. So I want to show you something. Look at this. This is diaphragm, okay? And if the kidneys were in the posterior abdominal wall, where would they be? They'd be really close to here. They'd be here. See, they're here. So what is behind the no? What is behind the adrenal gland? I want to show you the diaphragm. Wait. This is the diaphragm. And this is the right crest of the diaphragm. This is the left crest. And the like this is what lies posterior to the adrenal glands. This is the kidney. It lies right here, and there's a lot of structures on top of it. Pancreas, spleen, بس إنه it being at the back and what's posterior to it. And this is the kidney. Anterior to it, we talked about it. What's behind the kidney? It's the right and left crest of the diaphragm. For the right is for the right, and the left is for the left, obviously. That's it. That's the relations these are relations that you have to know. And if you forget something, just think about it logically. The kidneys are in the back, for everything would be like in front of it, and anything you can name is probably in front of it. And in the back, it's just a diaphragm because the diaphragm kind of, يعني, it extends to the back, you know. Anyway, moving on. The blood supply. There's three main arteries that supply the adrenal gland. You have the aorta here, and from the aorta you have superior adrenal artery. This is supplies the superior aspect of the adrenal gland. Obviously, it's from the aorta, and you have the middle adrenal artery, which is also from the aorta, and you have the inferior adrenal artery, which is not from the aorta, it's from the renal artery. The renal artery is from the aorta, but it's a branch from the renal artery. So the inferior adrenal artery is coming from down. It's easy to come from the renal artery because the renal artery is going to the kidney. It would come from the renal artery, not from the aorta itself. But from the aorta itself, you have the middle and superior adrenal arteries. So I wrote them here. The superior adrenal artery, it's a branch of the aorta. Oh, I forgot to mention that it's a branch from the inferior phrenic artery, just like the inferior. How the inferior is coming from the renal artery, the superior is coming from the inferior phrenic artery, and the middle one is the only one that's coming from the aorta because there's no other like branches here that could come out from. That comes from the aorta. Okay, venous drainage. This is very important, and remember how I told you that the inferior vena. Oh, I said mesenteric vein. I meant inferior vena cava when I said before. No, it's on the more on the right side. Inferior vena cava is more on the right side. Okay, for the left kidney, as you can see, this is the left kidney. It's semi-lunar shape. The adrenal gland is how you can differentiate, and because the left renal vein is longer. Why is it longer? Because the inferior vena cava is closer to the right side. If you would extend something from the right side going to the left side, it being close to the right side, it's just going to make it longer. For the left renal vein is longer, and the adrenal vein drains into the left renal vein. It doesn't drain to the inferior vena cava directly. It goes to the left renal vein, and this left renal vein is very high yield because other organs drain from there. You have gonadal veins that drain from there. It's not shown in this picture, but it's also called the hormonal vein because it has other like veins draining into it. It's a very important vein, the left renal vein, and it's longer, and it gets drained to the inferior vena cava, and the left adrenal vein drains into the left renal vein. For the right adrenal vein, it drains directly into the inferior vena cava, okay? The right adrenal vein it drains directly into the inferior vena cava. Is this clear? Inshallah, I hope it is. Just know the left renal vein is very high yield because there's other veins coming from down draining into it, okay? Okay, yeah, right adrenal vein, the inferior vena cava, the left adrenal vein to the left renal vein, and the left renal vein goes to the inferior vena cava. Okay, innervation, I don't think this is very important, but it was mentioned, so I'm gonna mention it. It's innervated by the sympathetic nervous system. And what is the function of أصلا the adrenal gland? It's to release catecholamines like epinephrine, norepinephrine. But it's sympathetic, and when you're nervous, when your sympathetic nervous system is activated, the adrenal glands releases these hormones. But from the sympathetic trunk, you have the greater splanchnic nerves, and they go to the adrenal medulla. You know how I said that there's a cortex and a medulla? They go to the medulla, and the medulla you have chromaffin cells, and I'm going to talk about it in histology. And when they when these nerves trigger the release of hormones in the medulla, what would you release? Epinephrine and norepinephrine, okay? This is when you're nervous, sympathetic nervous system is activated, and whatnot. I don't think it's very high yield, but just know, and know it's innervated by the sympathetic nervous system, especially the medulla. Okay, I'm gonna teach this in the form of a question because I didn't find anything that, from your manuals about the embryo, but this is a question that I found in past, so I was like, it's worth putting it, يعني, I wouldn't lose anything. So the adrenal gland, the cortex, how I told you there's a cortex, it's on the coelomic mesoderm, okay? But the medulla is neural crystals. And why is it that? Because it's, as you can see here, in all the nerves affected, epinephrine, norepinephrine. فجست the way to memorize it, neural crystals. For the medulla, which is in the middle, it's embryologically from the neural crystals, and the cortex is from the coelomic mesoderm, okay? Just know this. I don't know if they're gonna ask this, but I found this in a past question. These are like pictures, cadaver pictures that I got from your from your manuals. And this is the right kidney, and this is the right adrenal gland. It doesn't really show it's pyramidal, but if they would get you something, it would be more clear. This is the left kidney, this is the left adrenal gland. As you can see here, what is this? This is the artery. Why? Because it's more to the left side. And the vein, which is, where is it? I think I saw it here. I'm not sure, but this is the artery and it's closer. And the vein would be like farther away. It would be closer to the right kidney. They're probably gonna get something more clear, but these are the pictures that I found. Okay, here's where you can see, it's farther away. This is the vein and this is the artery. Okay, and this is the adrenal vein. It's going to the left adrenal gland, which is right here, and this is the left kidney. And this is the right kidney. What is this here? This is the left gonadal vein. I told you that left gonadal vein, where does it drain? It drains into the left renal vein. And why is it important? Because the left renal vein is also called the hormonal vein. It drains a bunch of other organs, and this is one of them. The left gonadal vein, it's going and it's draining, what's it called? In the left renal vein, and the left renal vein will go to the IVC. Yeah, that's all what you have to know here. This is the left renal vein, it's draining into it, okay? Oh, what's this? This is pancreas, this is splenic artery. I'll talk about this when we talk about the pancreas. Now let's talk about the histology. The histology for the adrenal gland is very important because they could ask you so many questions about this. But if you know the main concept, inshallah, you're good. Okay, I put this picture before, I'm gonna put it again. Just to remind you that there is a cortex and there is a medulla. Cortex has three layers, zona glomerulosa, zona fasciculata, and zona reticularis. Okay? These three layers, they're histologically different. They look different and you can differentiate them. The medulla is in the middle. And as you can see here, this is the medulla, it's this in the middle, and surrounding it is the cortex. ماشي? Okay, here, zona glomerulosa, fasciculata, and reticularis. This is the capsule. As I said, the capsule lines everything. This is the capsule. And if you would go deeper, more, after the reticularis, you'd find the medulla. Here again, capsule. This is the cortex, JFR, and the medulla, which is in the middle here. And as you can see, they look different. They don't all look the same. But it's easy to differentiate them when you zoom in. Why is it important? Why do we have these three structures? Because they all release different hormones. For the glomerulosa, the first layer after the capsule, it's kind of small. Look how tiny it is. It's very tiny. It releases aldosterone or mineralocorticoid. Okay, mineralocorticoids, aldosterone. And for the second part, which is the biggest part here, all of this fasciculata, is for the glucocorticoids, which is cortisol. Okay, for the third part, which is the reticularis, it's androgens like sex hormones, for example. But I will zoom in now to see how they look like under histology slides. So if they ask you about it, you can know. So GFR, first one is aldosterone, second one is cortisol, third one is androgens. Okay, And then we said here the medulla is epinephrine, norepinephrine. For the glomerulosa, the first part after the capsule, and as you can see here, it's very like easy to differentiate because you can see a capsule. You can see, a bunch of cells look the same, and then you can suddenly see a capsule. Why do you suddenly see a capsule? Because it's the outermost layer. They look like they look like clusters, and they have like a lot of like white in them. Okay, you can differentiate this from other ones. I'll show you the other ones, but you can differentiate this by seeing that they're kind of like clusters and they're more like circular. Okay, you can see like circular clusters. And what do they release? Aldosterone. And these are capillaries. They have capillaries everywhere. This is the glomerulosa. The fasciculata, it's the longest or the tallest layer, all of this. And how would you know? No, this is the what's it called? Fasciculata. You have foamy cells. You saw here that there's white, but they're more circular. They're circular. And when this one is like layers, it's like like they're arranged in long cords. They're more like layers, and you can't see the cortex here. They're like distinct layers, and they have large foamy cells. Here it's just like between the cells, and it's like clumps, yani it's clusters. Here it's more of like oh yeah, they are clusters, but they're not. Each one is on their own, and they're arranged in cords. And they secrete cortisol, and this is the most abundant part of the cortex, 75% of the cortex, okay? For the third part, which is the reticularis, which secretes the androgens, it's less lipids, you don't really see a lot of white, and it's more eosinophilic, and as you can see here, look how white this is, and look how red this is compared to it. They have, it's just the way you can know, and it's just more red, and doesn't have a lot of like white aspects. So as you can see here, it's spherical clusters, yani clusters that are more circular. Like look, a cluster that has a bunch of cells, a cluster that has a bunch of cells, a cluster that has a bunch of cells. And by this one, okay, they're the clusters, but each one is on their own, and they're very like white and foamy, and they're like cake in layers, and it's very long. For the reticularis, it's more eosinophilic, more red, more يعني purple, and they are nothing very specific about them, just know them by the color. And yeah, these are the three layers. Here, come on, another picture that I found in your histology slides. The glomerulosa is very close to the cortex, and they're kind of like arranged in like what's it called, like spherical clusters. The fasciculata, look how it's like, you can see, it's like a layer, like one layer, two layers, three layers. The reticularis, it's more purple, more red. It's less foamy. It doesn't have a lot of foamy cells. And this one secretes aldosterone. This one secretes cortisol or glucocorticoids. This one secretes androgens. Okay. Moving on to the medulla, which is here in the middle. This is the reticularis, and then the medulla comes after it. So another picture here. This is all the cortex, and in the middle is the medulla. And what do we have here? A central adrenomedullary vein, and it's in the middle, like exactly in the middle of the medulla. Okay. And there's nothing much that you can like identify here except for the chromaffin cells. And these cells, honestly, they look very similar to anything that I showed you before. So I think if they were to get you something like a picture like this, it would be more zoomed out, so you know exactly where you're looking at. So the chromaffin cells, what do? They have neurons, because what did we say this? Where is it derived from? Neural crest cells. What do they synthesize when they're innervated by the neurons? They synthesize catecholamines, or like uh, epinephrine, norepinephrine. So this is the central adrenomedullary vein, and this is the medulla, which is in the middle. And then you have the chromaffin cells. Where are they? The C chromaffin cells, and they're neurons. Okay, let's move on. This is the pancreas. The pancreas is it wasn't very like elaborated on, so I'll just mention the very high yield things about the pancreas. So the anatomy, it's in the back. Look, this is the stomach. It's anterior to it, and it's in the back. So this is just what I wanted to mention. And it's some parts of the pancreas. It's in the middle here between the stomach and the duodenum, the intestine. This is the anatomy. This is the spleen. Okay, and attached to it, or not attached to it, but close to it is the tail. Then you have the body, neck, head, and uncinate process. The uncinate process is what lies in the middle. Yeah, this is the duodenum. This is the duodenum. The uncinate process is heiki, just lying in the middle and close to the head. As you can see here, this is the uncinate process at the end. This could be the head, come on. So tail, body, neck, head, uncinate process in the C-shaped duodenum. Okay, this is the spleen. Okay, so how would you know? No, I'm looking at the pancreas now. How would you know this is the pancreas? What is this? This is the spleen. And what is as like very close to the spleen? The tail of the pancreas. And then you have the body, neck, head, and this is duodenum. Look how it's like, يعني perfectly, subhanallah, perfectly shaped or sat inside the duodenum. This is a superior mesenteric artery, and this is the splenic artery. It's يعني across the pancreas and it supplies the pancreas. Okay, but this wasn't mentioned. The blood supply was not mentioned, but I don't know if you have to know it. But just know, there's specific parts of the pancreas, and you can know, you're looking at the pancreas because look at the stomach and the omentum were like they were removed, and this is the duodenum, which is part of the small intestine, and the pancreas sits perfectly inside it. And this is the spleen, tail, body, neck, head, and the uncinate process, which probably isn't showing here, but it would be here, like somewhere here. Okay. Okay, moving on. This is another picture that I got. This is a greater omentum and the stomach. I told you they put them up so you can see the structures that are posterior to the stomach, which is we're looking at what are we looking at? The pancreas. This is the spleen, the superior mesenteric artery, superior mesenteric vein. Oh, I was right. It's a superior mesenteric vein. Anyway, just know that the vein is on the more on the right side. This is the liver, so you would know in all this the vein is on the right side. This is the pancreas. It's coming from the spleen, with and it just it gets situated in the duodenum. Okay, that's it. This now we're gonna talk about the histology. For the pancreas, there was only this slide, and it's very important. I think if they would get you something, they would get you this because it's very easy to differentiate. And you can see here, there's like a lot of fake cells here, acini, but there's like something distinct here. What is this called? Islets of Langerhans. Okay, what do they contain? These islets of Langerhans. They have A, B, and D cells, and they secrete insulin and glucagon directly into the blood. Okay, so these islets, they have these cells which secrete insulin and glucagon, okay? And you have this is the endocrine portion because we're talking about hormones. There's also the exocrine portion, which we're not very involved in now, but just know in the pancreas has two parts, the exocrine and the endocrine. The endocrine is what we care about, and the endocrine portion, there are clusters of cells called the islets of Langerhans, and they have A, B, and D cells which secrete insulin and glucagon. And even if you didn't know this, the pancreas secretes insulin and glucagon. This is another picture that I found in one of the past OSPEs. If they could get you this is the islets of Langerhans, and around it is the rest of the pancreas, but just know that this secretes insulin and glucagon, okay? This is the only histology slide that you guys had for the pancreas. Okay.
Hello again, everyone. Now we have the reproductive system, which we've divided into general repro, male repro, and then female repro. Okay. For the first part of general repro, we have the dry lab. Okay. The first thing that you guys took in dry lab was the pelvis. Okay. So this is what the pelvis looks like. Okay. Here we have the hip bones, or another name for them is the innominate bone. Okay. And then as you guys can see here, we have the femur. You don't really have to know that. But it's just basic knowledge. Now, in the middle, at the back, we have the sacrum, okay, and the coccyx, which is right below the sacrum. Now, the innominate bone plus the sacrum plus the coccyx, all of them together make the pelvic brim. Oh, no, the pelvis, sorry. Okay. Now, this circle here is what we call the pelvic brim. Okay. Now, these are the three bones. Here we have the ilium, we have the pubis, and we have the ischium. Okay. And in the middle between the two pubis, we have the pubic symphysis. All right. And at the back, we have the sacrum. Now, if we put a plate, okay, in the opening of the pelvis, it divides the pelvis into two parts, an upper portion and the lower portion. The upper portion here, everything above the plate will be called the false pelvis, okay? And then the plate itself is the pelvic brim, okay, which is here, the sides that make up the circle. And then anything below this plate will be called the true pelvis. Now, here is the hip bone again. Okay, here we have the ilium, we have the ischium, and we have the pubis. They join together to make a Y-shaped triradiate cartilage. That is the name. Okay. So the triradiate cartilage in the middle, it's Y-shaped between the ilium, ischium, pubis, and it's found in the acetabulum. Now, this is your acetabulum here, which is this round circle here, in which the femur goes, like the head of the femur goes into this acetabulum. And then we have the ilium on top, ischium here, and pubis. Again, this is just another view. Now, the outer surface of the pubis and the ischium, they form attachment sites for muscles to attach, specifically the thigh muscles. Okay. Now, here's the lateral view of the hip. As we said, this is our acetabulum. Then here we have the pubis, here we have ischium, and then here at the top we have the ilium. Now, unfortunately, Dr. Atuf said you guys have to know all of these. Okay. However, I've highlighted the ones that you guys should like definitely know. I know there are lots, but with repetition, they're going to become easy, inshallah. طيب. Now, I'm going to leave them to you guys. However, I'll just mention the most important ones. Acetabulum, of course, the circle here. Then we have the anterior superior iliac spine. Then we have the anterior inferior iliac spine. And then at the back, we have the posterior superior iliac spine. And then at the bottom, we have posterior inferior iliac spine. Okay, then we have the greater sciatic notch, which is right here. All right, as you guys can see. And this is our ischial tuberosity. Here, this pointy thing is called the ischial spine. Okay. And then we have the obturator foramen. Now, as we said, this is the ischium, so it gives an ischial ramus. And then here is our pubis. We have a superior pubic ramus and the inferior pubic ramus. Then we have the pubic tubercle at the bottom here. And I think that's mostly it for this part. I think so, yeah. All right, just go over these and make sure you know them very well. Now, this is a medial view, okay? Now, how did we know it's medial? Because we can see the auricular surface, okay? What is an auricular surface? It's the surface of the ilium that is attached to the sacrum, okay? If we go back a couple slides, okay, yeah, here. Can you guys see? This is, like, if we remove the sacrum and we look at it from this side, from the medial side, we're going to see the auricular surface. Okay. And we can also see the iliac fossa. Now, in the iliac fossa, we have the iliacus muscle. Okay, it attaches there. However, I don't think you guys need to know that. I think that's an MSK, or you guys took it in another block. It's not really needed here. Just know it, because why not? Okay. Now, one thing that was written in your slides, and to be honest, personally, when I look at the pelvis, I don't really see it. However, it was mentioned. So if they ask you for differences, you can say it. Is that in males, this greater sciatic notch is J-shaped. Okay. And in females, apparently it's L-shaped. Okay. So it's like, it's a lot more sharper in females. However, I don't really see it. You can just memorize it as is. You don't really have to see it. Okay. So the two new things, everything here is the same as before, like from the slide before this. The two new things that we added are the auricular surface and the iliac fossa. Okay. Now, this is like you're looking at the hip from above. It's a superior view. Okay. So here we have, can you guys see this line here? Now, this line is called the pecten of the pubis. Okay. Now, remember the true pelvis and false pelvis when I mentioned it, and we put a plate with a circle. Wait, actually, let me go and show you the slides. One sec. Okay, yeah, here. So can you guys see the circle? Now this is the pecten. Okay, here. Pecten of the pubis. This side. Okay. So this are pecten of the pubis over here. Then we have the pubic crest. This is the only thing that is new. And we also have the arcuate line. Now, this is our arcuate line. Here's our pecten of the pubis. Oh, I mixed them up. Okay, so yeah, this here is our arcuate line, the one at the top. And then at the bottom, we have the pubic crest. Okay, these are the only two new things in this slide. Okay, now if we look at it from the bottom and behind, so basically posterior inferiorly, we can see the bones that we sit on actually, and they are the ischial tuberosity. So the ischium is the posterior inferior bone, and to be like the specific landmark that we sit on is called the ischial tuberosity. Okay. Now the new things are the acetabular notch, and I don't think you really need to know that. Here we have the acetabulum. Remember the circle in which the femur's head goes in. Then we have the rim of the acetabulum itself. Okay. And then we also have the obturator foramen here. Okay. And this, there's like a depression in there. I'm not really sure if you guys can see it. It's not really clear in this image, but there's supposed to be a depression, and that is called the obturator groove. Okay. And remember, we said earlier that the ramus of the inferior ramus of the pubis and the ischial ramus, they join together, okay, to make the obturator foramen. Okay, part of the obturator foramen, the bottom side. Now, this, like the rami, when they fuse together, we call them ischiopubic rami, ischiopubic ramus. Okay, and we mentioned earlier that this is our ischial spine here at the top. Pretty sure. Yeah. Okay. Yeah. This one. I'm sorry, guys. This one is the I'm sorry, the what's it? The ischial spine here at the top. And then sorry, pause. Three is our ischial spine. And then here we have the lesser sciatic notch. Okay, because it's a notch. Now, if we look at the hip anteriorly from the front, we can see the anterior superior iliac spine. And then let me go back actually to show you guys something. Or خلاص, I'll show it in the review. Okay. So this is from the front, as we said, anterior superior iliac spine and acetabulum, obturator notch, obturator foramen. And then we have the pubis, we have the ischium, we have the ilium. Just review everything all over again. These are just different views of the pelvis. Okay. You have to know the landmarks very well. Okay. This is also a general overview for everything. Okay. Here we have the ilium. Then at the bottom, we have both the pubis and the ischium. Okay. Go through every single label and make sure you know it very well. Okay. Because you never know what they can ask you. This is another model from the lab. Okay. As you guys can see, the obturator crest is I'm not really sure if it's clear. However, it's supposed to be like something that is poking out. A groove would be the depression. Okay, so obturator groove is a depression in there. And then crest is something that is poking out in the obturator foramen. Okay. Now this is our pubic tubercle, as we said. So all of these are pubis over here. This is the superior ramus of the pubis, and then the inferior ramus of the pubis. And here we have the ischium, ischial tuberosity. And then we have the iliac crest over there, that dome-shaped structure, like all over from the aces to the pieces. It's called the iliac crest. Okay, I'm not sure it's labeled here. Yeah, it's not. Anyways, like, just know that part is called the iliac crest. Okay. Now for the sacrum, okay, you just have to know what it looks like, صراحة. And one thing you should really know about, like one thing to point out about the sacrum is the promontory. طيب, because it's different in males and females and it's a point of differentiation. Another thing is the curvature. Okay. So basically, this is our sacrum. Okay, these are the sacral foramina. Okay, now through these we have the ventral rami of the nerves of the sacral plexus that poke out of the nerves that form the sacral plexus. Okay, so from the back they come through the foramina. The nerves come out through the foramina. They join together to make our sacral plexus. Okay. Now remember in the ilium, we said we have an auricular surface, which is the articulation point with the sacrum. This is the articulation point here. Like when you look at the sacrum from the side, you can see it. Okay, so this goes on the auricular surface of the ilium. I can go back a few slides to show you. Yes, this one. There's the auricular surface. Okay. So these two surfaces are stuck together and they form our sacroiliac joint. Okay. Now, to differentiate, we have in the female, طيب, the first three sacral bodies are straight. Okay. And then they have like a slight curve towards the end. So it's more J-shaped, I guess. Okay. Or L-shaped, however you guys see it. This is to facilitate in childbirth so that it doesn't like obstruct the child's head when it's coming out. Okay. However, the male's sacrum is like more uniformly curved. It's like a full curve from the start till the end. Okay. So yeah, that is it for the differences between males and females. And just know that this surface, this side here, is called the pelvic surface. Okay. Why? Because it's towards the pelvis. Remember, we mentioned the true pelvis. Okay. So this is the pelvic surface. And then at the top, this notch here is called the sacral promontory. Okay. We said that it's different in males and females, and I'll show you the difference in a bit. Okay. And on the sides, we have the auricular surfaces that we said articulate with the ilium to form the sacroiliac joint. All right. Here it says that the males have a wider S1 body. Okay. However, I don't see it, صراحة, but just know it just in case. Okay. So in males, the S1 body is wider than females. Okay. I think this is just a repetition slide. Yeah. Here we have female, and then here we have male. So can you guys see, like if we look at it from the side, I couldn't find pictures from the side, but if you look at it, it's going to be a lot more curved, uniformly curved in males. Okay. And in females, it's a lot more L or J-shaped structure. Okay. So here, as you guys can see, 1, 2, 3, more flat and then curved. So this is female. Okay. And then this is more uniformly curved. So this is male, obviously. Okay. Now, first, okay, remember when I mentioned earlier that the males have a wider body, wider S1 body. So can you guys see it here? It's a lot more clear on this section. طيب. As you guys can see, the the male S1 body is a lot more wider than the females. Okay. And then also another point is that you guys have to know the different parts of the sacrum. I'm sorry, this is supposed to say sacrum here at the top. I'll fix it later. طيب. So here we have the lateral part of the sacrum, okay? And anything that is lateral is also called a wing or ala. Okay, this is just extra info, you don't really have to know it. طيب. And then as we said that the protruding part at the top is called our sacral promontory. Yes, exactly. Sacral promontory. Okay. This is the canal. As you guys can see here, there's a hole. طيب. Now this is the sacral canal through which the spine can go through, which you don't really have to know it. طيب. Then we have here, this is the spinous tubercle. Okay. Number 6. And then we have the superior articular process, which is the point which attaches to the lumbar, what's it called? The lumbar vertebra. So it's an articulation point between the sacrum and the lumbar vertebra. Now from superior articular process to the spinous tubercle, we have this connection here between them. Any connection between these two in all parts of the vertebra is always called the lamina. Okay. And I think these are the different, all the different parts of the sacrum. That's all you need to know. صراحة. And also know the differences between male and female, wider body, more prominent sacral promontory in males. And I think that's it. Oh, and also in females, the S1, S2, S3 are a lot more flat and then curved towards the bottom. However, in males, it's a lot more uniformly curved. طيب. Now for the ligaments. طيب. This is a slide straight from Dr. Atif. Okay. The most important things that I want you guys to note are the greater sciatic notch over here and the lesser sciatic notch, because we're going to form attachments now that will turn them into foramen. Okay. Now, here we added some ligaments. Okay. As we said, this is the sacrum, right? And this is our ischial tuberosity here at the bottom. So from the sacrum to the ischial tuberosity, we're going to have a sacrotuberous ligament. Okay. And this is our ischial spine. So from the sacrum to the ischial spine is going to be from the sacrum to the ischial spine is going to be sacrospinous ligament. Okay. So here we have the sacrotuberous, sacrospinous. All right. Now these two, okay, will turn the notches into foramina. طيب. Here at the top, we have the larger one, which is the greater sciatic foramen. And then at the bottom, we have the lesser sciatic foramen. Okay. We also have here from the sacrum to the ilium, we have a ligament, which is called the sacroiliac ligament. Okay. And I think these are the three ligaments. That's it. Also, yeah, you don't really have to know this. Like you won't be asked about it. However, the foramina are made for like blood vessels to pass through. Okay. However, you might need to know structures that go through it, which are later going to be explained. Okay. All right. Here we have the different joints again. طيب. We mentioned earlier that between the sacrum and the ilium, we have sacroiliac joint. You can't really see it because it's covered by the anterior sacroiliac ligament here. Okay. And there's also an iliolumbar ligament. So this is the ilium. The sacrum starts here. Okay. So this is the lumbar part. Okay. So from the ilium to the lumbar spine, okay, we have the iliolumbar ligament here, as you guys can see. Okay. Then we have the anterior sacroiliac ligament, which cover the sacroiliac joint from the front, as we mentioned. These are the two ligaments that we mentioned earlier. Here's the sacro. Can you guys see? The spine is, you really can't see from the front, but the ischial spine is here at the back. So sacrospinous, and then the tuberosity is here at the bottom. So sacrotuberous. Okay. And here in front, we have the pubic symphysis. Just know that the pubic symphysis is fibrocartilaginous. There's something that is important. They might ask you about what type of tissue is found in pubic symphysis. And the sacrococcygeal joint is here between the sacrum and the coccyx here at the bottom. Okay, this one is also a cartilaginous joint. Okay, so there is slight movement between the sacrum and the coccyx. And something that is surprising is that the sacroiliac joint is synovial. However, it's a plain synovial. I didn't write that here, so make sure to remember that. It's a plain synovial joint. Okay. Dr. Atif gave a whole table about the sacroiliac joint, so make sure to revise it well. Okay, I'm just going to keep it here for a few seconds. You can pause the video and read it. Okay. Now here's another table that shows the differences between a male and female pelvis. Okay. This was also provided by Dr. Atif. Okay, you can pause and read. All right. Now, back to our ligaments. From the back, we have, I'm sorry for the confusion, guys. Those slides should have been towards the end. So here we have the sacrotuberous ligament, as we said, from the sacrum, okay, towards the ischial tuberosity. So sacrotuberous, okay. What else do we have? We have the sacrospinous, as you guys can see here at the back. Let me zoom in actually. So we said that this is the ischial tuberosity. Here we have the ischial spine. So from the sacrum towards the tuberosity, we have the sacrotuberous ligament. From the sacrum to the ischial spine, sacrotuberous ligament. Okay. Here we have the greater sciatic foramen and the lesser sciatic foramen at the bottom. I think that's all you need to know from the side. Yeah. Okay, here are more pictures with pelvis. It's a bit blurry, but these are all the pictures I could find صراحة. طيب, again, pubic symphysis, obturator foramen. Here we have the ischial tuberosity here. So from the sacrum to the tuberosity, you have the sacrotuberous ligament. Okay. And then the ischial spine is not shown here. It's at the back. Okay. Sacrospinous ligament. Then we have greater sciatic foramen, lesser sciatic foramen. There's another ligament here from the asus to the pubic tubercle, which is called the inguinal ligament, as you guys can see. طيب. And here we have our acetabulum. Okay. Again, from the ilium to the lumbar vertebra, we have the iliolumbar ligament. Okay. And I think that's it. Yeah, here are another views. Okay. Here, this one is a lot more clear. Okay, you can see the sacrotuberous at the back, okay, towards the tuberosity, and sacrospinous ligament. Okay, I hope it makes it a lot clearer now. Is there anything new here? No. Okay. More pelvis. Now from the back, you can finally see it. All right. We have from the sacrum to the ischial tuberosity, we have the sacrotuberous. Then to the spine, we have the sacrospinous. Okay, and these are the two foramens, greater sciatic foramen, lesser sciatic foramen. Okay. Now the differences between a male pelvis and a female pelvis, I'm going to go over the male first, and then we're going to go through to the female. So, as you guys can see, the male pelvis, the first thing is that the inlet itself, the pelvic inlet or the pelvic brim, okay, it says here it's anteroposteriorly, which basically means and it's more like stretched from front to back. Okay. However, if we go to the female, as you guys can see, it's a lot more oval shaped. So it's transversely stretched. Okay. So can you guys see how oval it is? And then male is a lot more circular. So this is anteroposteriorly oriented, and that one is transversely oval. Okay. Now, the space between the two ischial spines in males is closer to each other than females. Now, all of this is just to facilitate childbirth in females. Okay. So in females, can you see how wide it is? The ischial spines, they're widely apart. Okay. So anything in males is a lot more compact and like smaller than females, mostly. Okay. Here again, remember when we said that ala means wings, or like anything that's on the sides. So again, here, the sides of the ilium are called ala. Okay. So they're a lot more less flared. So they're not really like spread out. Like the wings are not spread out as in females. Okay. It's not really clear here in the pictures. However, like the male's pelvic, the male's ala are a lot more compact like this than females. Females have it a lot more flared to the side. Okay. This also like increases the space available for the child to come out. Now back again to the sacrum. Okay, remember this sacral promontory. It's a lot more anterior in males than females. Wait. Okay. Here in females, the promontory is pushed back a bit. Okay. Now, why is that? So that the child's head doesn't hit it when it's coming out. Again, we said that the sacrum here is less curved, it's a lot more straight, and then it bends towards the end. Other than other than the sacrum. Oh, here in males, okay. In males, we have it a lot more curved. Yeah. And I think these are all the differences. So everything in males is what? Compact and closer to each other. Everything in females is widely spread and is more like spread out to provide space for the child to come out. Okay. Now, again, here are more differences. As you guys can see, this arch here is called the pubic arch. In males, it's a lot more angled. Okay. In females, it's a lot more of a curve. And as we said, the sacral promontory is poking out more. One more thing is that the obturator foramen in males is O-shaped. However, in females, it's oval shaped. And to be honest, is it mentioned here? It's not mentioned. I think it's mentioned later. Okay, I don't really see it, but just memorize it again. طيب. So in males, the obturator foramen is a lot more O-shaped. In females, it's oval shaped. Okay, and the pubic arch in males is a lot more angled than the females. As you guys can see here, in females, a lot more curved and it's wider. طيب. and the sacral promontory is pushed back in females. Okay, here are different views for the male and female pelvis. Okay, so as you guys can see here at the top, we have male. As we said, the arch in males is a lot more angled than females. Females is curved, طيب. And in females, it's a lot wider, طيب. And from the back, as we can see, I'm not really sure if you can really appreciate how straight the sacrum is in females at start, and then it curves towards the end. And in males, it's a lot more uniformly curved. Oh no, sorry. Yeah. Here in males, okay, it's a lot more uniformly curved, and females it's a lot straight. Yeah. Yeah. So it's straight and then it bends towards the end. Okay. And the pelvic inlet in females is a lot wider, okay, than males here. Can you see how small it is? So basically females have a bigger Mickey Mouse face than males. Okay. So the Mickey Mouse in males is smaller than female. And one last thing is that the ala here, I know it's a top view, so you can't really see it, but it's a lot more flared. You can see it here in the anterior view. Can you see how flared it is? Like it's opening towards the sides than in males. In males, it's a lot more compact together. Here are different models from the lab. Male, female, pubic arch, pubic arch. Here it's a lot more angled, a sharper angle. Here it's a lot more curved and it's wider. And the sacral promontory is more protruding in males. It's less protruding in females. And the ala are more flared in females. In males, it's a lot more closer to each other. And the pelvic inlet is wider in females than males. Okay, so I've repeated this multiple times because you will be asked about this. Now, this is an X-ray. Okay, so from this X-ray, we can tell that it's a female. Okay, because no, it's a male. Sorry, yeah, it's a male. Okay, because the arch here is a lot like sharper. Okay, the pubic arch is sharper. And what else? What's another difference that we can tell in? I guess we can tell that the ala is not flared, okay, as seen in females. Because when you see the female, can you see how flared it is? It's a lot wider. Okay, and the subpubic angle or the pubic arch is a lot more curved, round than sharp. And can you see the difference in the obturator foramen? You really can't, صراحة, in the X-ray. However, you can mention stuff that is different in general. طيب, so you can say a wider pelvic inlet, a more protruding sacral promontory, anything, okay? Just to get the points. So the most obvious thing is the subpubic angle. Okay. Now for the muscles, this is the view from the medial side, okay? Now when you look at the pelvis from the middle, from the medial side, sorry, we can see this first muscle here at the back from the sacrum through remember this hole here, this opening, which is our greater sciatic foramen, طيب. So we have the piriformis, طيب. Then here we have our obturator internus, which covers the obturator foramen, okay? And we can also see the levator ani muscles. Then at the back here, from the sacrum to the ischium here at the back, we can see the coccyx. Okay. So let me just make sure I didn't miss anything. Okay, here we have the tendinous arch of the levator ani. So levator ani attached to the obturator. So obturator internus is behind, like this is the top part of the obturator internus, and then it continues downwards below the levator ani. The levator ani attaches at the obturator internus, and it forms something called the tendinous arch. Okay. Now here I have the functions written for the pelvic diaphragm or the pelvic musculature, which is basically to support the pelvic viscera. Okay. We also have the sphincteric control. So in order for you to like hold in your number one, number two, okay, and to not have urinary and fecal incontinence, you need these muscles, okay, and they also help like they can withstand increased intra-abdominal pressures, okay. So like when you strain, for example, or something, your pelvic organs don't just fall because of these muscles, okay. Now, if we have an injury to these muscles, the pelvic organs, like the rectum, for example, they can fall out. And this is something called prolapse. Okay. We have two actually. We have rectal prolapse and uterine prolapse. I have pictures later. Okay. And that's mostly it. So I have for this slide. You have to know the different muscles really well. Okay. Now, for the okay, the slide is over. Okay. For the levator ani, okay, we have different muscles that make it up. We have the iliococcygeus, we have this puborectalis, and we have the pubococcygeus. Okay, all of them together are the levator ani. Now, as we mentioned earlier, from the sacrum, okay, through the greater sciatic foramen, we have the piriformis. Remember these? Remember these ligaments here? These are the sacrotuberous and sacrospinous ligaments. Okay, so they make the foramens, the greater and lesser. Now, through the greater, we have the piriformis. Through the lesser, we have the obturator internus. Can you see it here? Um, yeah, so how to memorize these muscles? The name is basically the sites of attachments. So puborectalis, what does that tell you? So that it goes from the pubis طيب, towards the rectum and actually slings around the rectum and attaches back to the pubis. I think you guys took this muscle in GIT, okay, which is the sling that makes the angle, the rectal angle, which helps us to control our feces. And then we have the pubococcygeus, okay? So basically from the pubis, it's not really clear here, but it comes and attaches at the coccyx. Okay, so pubococcygeus. All right. And then we have iliococcygeus from the ilium, again, from the ilium to the coccyx, so iliococcygeus. Now this forms the posterior sheath, okay? And these two are anterior. Now let me just see if I missed anything. Here's the pubococcygeus from the pubis to the coccyx, puborectalis, slings around the rectum, obturator internus, which goes through the lesser sciatic notch, piriformis, which goes through the greater sciatic foramen, and I think that's it. Okay. Now, this hole at the front here is called the urogenital hiatus. Okay, hiatus means an opening. Okay, and this are anal hiatus. Okay, so urogenital hiatus, anal hiatus. Through the anal hiatus, we have of course, the anus. Okay, and then the puborectalis we mentioned earlier, from the pubis to the rectum, and it slings around it. And then from the pubis, طيب, to the coccyx. Here it's a lot more clear than the first picture. Can you guys see here from the pubis to the coccyx? So pubococcygeus. And then this is our ilium. So from the ilium to the coccyx again, we have the iliococcygeus from both sides. Now all of them together are the levator ani. Now all of them, they attach on the obturator internus and they form something called tendinous arch of levator ani, which is basically a tendon. طيب. And then here at the back, we have the coccygeus. Okay, it's removed on this side. Here we have the coccygeus, and behind it we have the piriformis. Piriformis goes through the greater sciatic foramen. Okay. Now, if they ask you which two muscles make the pelvic floor, okay, you have to say levator ani and the coccygeus, okay? Because they refer to these three muscles together as levator ani and this alone as coccygeus. Okay. Okay, here it says that the pelvic diaphragm is basically gutter shaped. Now, gutter shaped is anything that is curved like this, like when you do prayer hands, okay, it's like a curve. طيب. So it's curved. gutter shaped. And it says that it separates the pelvis from the perineum. Okay. Now, we mentioned that this is our true pelvis here. طيب, anything below this is our pelvic brim. طيب. And the floor is the pelvic diaphragm. So between them, we have the true pelvis. Anything below those muscles is called the perineum. We're going to explain the perineum later. Okay. And it says here that it's incomplete anteriorly because we mentioned the urogenital hiatus through which the urethra and vagina pass. Okay. Okay, here's a model. As we mentioned, piriformis through the greater sciatic foramen, obturator internus through the lesser sciatic foramen. طيب. Now, when you look from the outside, you can't see the pelvic diaphragm. You can't see the levator ani and coccygeus. You can see the coccygeus, but you can't see the levator ani. Why? Because we have the perineum muscles here. طيب. Just keep that in mind for later. I'm going to dive into the perineum muscles in a later section. طيب, so this is just another view. Okay, here's another view from the middle side of the model. طيب, as you can see, piriformis. Now, how can you tell this is piriformis? It has the sacral plexus running in front of it. This is the sacral plexus, which is basically a bundle of nerves. طيب. Now, we have the piriformis muscle lying behind it. طيب. And then we have the coccygeus and then the levator ani. And you can identify the levator ani from the tendinous arch that it makes with the obturator internus. All clear? Here's another view. As we mentioned, at the back with the sacral plexus, behind the sacral plexus, we have piriformis. Okay. Then we have coccygeus. Then we have levator ani. Okay. And the different parts of the levator ani we have here, pubo, rectalis, slings around. And then we have ilio from the ilium to the coccyx, iliococcygeus. And then from the pubis to the coccyx, we have pubococcygeus. Okay. It's better shown on the side. طيب. And the landmark here, the tendinous arch of the levator ani and obturator internus. Okay, all clear? Now, here's another slide about them. Make sure you know them very well. طيب. And you need to know like the different fibers, like the sides. So we mentioned here anteriorly, we have the two puborectalis muscles, okay, that sling around the rectum. So these two are anteriorly. طيب. We also have alongside it, we have the pubococcygeus, طيب, to the coccyx. And then we have the posterior fibers here, which are the iliococcygeus, from the ilium to the coccyx, iliococcygeus, طيب. And then we have the obturator internus, which is behind the membrane. Okay, it's removed on the side here. You can see it, obturator internus. And this is the tendinous arch of the levator ani. Then we have our coccygeus at the bottom, piriformis here. We mentioned piriformis through greater sciatic foramen, coccygeus through lesser sciatic foramen. I've mentioned it multiple times so that you remember it. Okay? Now go over these slides over and over again. Make sure you memorize the different muscles, also like in different orientations. Okay? Here we mentioned that the urethra passes through, and here the anus. Okay? Okay. Now in females, we have the endopelvic fascia. Okay. Now these are basically thickenings that keep the structures in place. طيب. So here we have the cardinal ligament. The cardinal ligament has the uterine artery. Remember, water under the bridge. Don't forget that. طيب. So uterine artery, which is below the cardinal ligament, which is below the ureters. طيب. Sorry, the ureter is below the cardinal ligaments. That's why it's water under the bridge. Okay. So here, number one, we have cardinal ligament, which has the uterine artery. Then we have from the sacrum. Can you guys first appreciate that this is the backside, this is the anterior side, right? So from the sacrum to the uterus, we have uterosacral ligament, which helps keep the uterus in place. And then from the pubis to the uterus again, however, like towards the bottom side of the, here it's not really shown, however, it's towards the bottom, so it's more towards the cervix. So it's called the pubocervical ligaments. Yeah. So the three ligaments that keep the uterus in place are cordon ligament, which has the uterine artery, two, uterosacral, طيب, uterosacral, طيب, and the last one we have is pubocervical. Okay, from the pubis to the cervix. And these are the different landmarks. You don't really have to know them, صراحة. Okay, sorry for the blurry picture, but this is also something I found in the slides, and I like this one more because it shows you like it's a lot more realistic than that one. طيب. So from the pubis to the uterus, طيب, uteropubic ligament, uterosacral, sorry, sorry, excuse me. طيب, uterosacral, this is the sacrum over here. طيب, at the back, there's not the pubis. Pubis is at the front. Okay, so we have uterosacral, طيب, from the uterus to the sacrum, uterosacral ligament. Then we have the cardinal ligament, which has our uterine artery. طيب, and then lastly, we have our um, pubocervical ligament. Yeah, pubocervical. Okay. I think that's it for this slide. There's nothing. Okay. Yeah. Now, again, if these ligaments, if anything happens to them, we said that they hold the uterus in place. Okay. Now, if the structures that hold the uterus in place get damaged or injured, the uterus is obviously going to fall. It's going to collapse. Now, this is called uterovaginal prolapse. Why? Because the uterus falls into the vagina. So uterovaginal prolapse. Prolapse means that the organ falls out of the body. Okay, and this can be due to injuries, as we mentioned, or if a lady has multiple childbirths, because it like stretches out the vagina and everything, like the uterus and all, and it can damage the facial thickenings that we have, the cardinal ligament in them. So if they get damaged, obviously it's going to fall, and this is called the uterovaginal prolapse. Now, this is a recall slide. I want you guys to pause and try to solve. طيب, name the different ligaments. The answers you can find in the old slide, the previous one where I explained. طيب, blood supply. Okay, now this is a bit too much to take in. طيب, however, here we have our abdominal aorta. From the abdominal aorta, we have the common iliac. Specifically, this is the right one. طيب. Then the common iliac gives us two branches, which are internal iliac, which goes to feed the internal pelvic organs, and external iliac. We don't care about the external iliac. طيب. Our main focus is the internal iliac. Now, the internal iliac divides into two branches, anterior and posterior. طيب. Now, the posterior branch gives us three arteries, which are the iliolumbar and the superior gluteal, and I love steak, iliolumbar, lumbar branches. طيب. Lateral sacral, sorry. Lateral sacral, yeah, here. طيب. I'll show you the mnemonics later. طيب. And then we have the anterior branch. The anterior branch gives us many arteries. طيب. I'll show you guys on a model that's better to see. طيب. Here. Can you guys see all of these arteries that come from the anterior branch? Now, a small mnemonic that I made is stupid old iguanas visit underwater markets in Istanbul. طيب. So, stupid, S, superior vesicle. طيب. Now, superior vesicle goes to the bladder. طيب, supplies the bladder. Vesicle means bladder. Then, old, O, obturator. طيب, obturator artery. Then, iguana's I, inferior vesicle in males. طيب, and visit vaginal in females. Okay, because this is different between the two. طيب, so the inferior vesicle artery in males and the vaginal artery in females. And then underwater, uterine, markets, middle rectal, then inferior gluteal, and then Istanbul, internal pudendal. Okay? So for the posterior branch, we have Isle of Steak, which is iliolumbar, lateral sacral, and superior gluteal. And then for the anterior branch, we have stupid old iguanas visit underwater markets in Istanbul. Superior vesicle, obturator, inferior vesicle, and vaginal females, uterine, and then middle rectal, inferior gluteal, internal pudendal. Also, uterine is not present in males. It's only in females, obviously. And yeah. Now here is what they supply. So basically, as I mentioned, superior vesicle is urinary bladder, as we mentioned. Obturator, remember the obturator muscle? It's part of the thigh muscles. So the obturator artery will provide blood supply to the medial thigh muscles. And then we have the inferior vesicle, which goes to supply the bladder and the prostate and seminal vesicles in males. And the vaginal supplies the vagina and a small part of the bladder. And we also have the uterine, obviously to the uterus, middle rectal to the rectum, internal pudendal to the perineum, and external genitalia. طيب. Now, these are the different arteries that you need to know. I'll try to make a small mnemonic so that you guys can memorize them. So I hope it helps. Here's another diagram. Here's our common iliac splits into external and internal. External. Okay, I think this is a mislabel. I found in Dr. Atos slides, but I think this is the internal iliac, yeah. But then it separates into posterior branch, which has the Isle of Steak, iliolumbar, lateral sacral, and superior gluteal, and then anterior, which is the other 7 that I mentioned. طيب. Now, pudendal nerve. This is something that is really important. طيب. Now, the pudendal nerve is kind of weird and it has a weird course that it takes. طيب. So it comes out of the sacral plexus. طيب. From specifically S2, S3, and S4. So they join together. طيب. And here we have our piriformis muscle. طيب. Remember, we mentioned that piriformis will always be behind the sacral plexus. طيب. For these 3 go in front of the piriformis muscle and they join together. طيب. Now, when they join together, they give us the pudendal nerve. طيب. Now, this pudendal nerve, it goes out from the pelvis. طيب. So out of the pelvis, it goes through the greater sciatic foramen. طيب. And then you can think of it as like it wants to breathe and come back. طيب. That's what Dr. Aylin said. طيب. So it goes out of the pelvis through the greater sciatic foramen, and then it goes back into the pelvis. So it goes back in through the lesser sciatic foramen. طيب. And then it passes into something called the Alcock's canal. طيب. And it gives us 3 branches. It gives us the dorsal nerve of the clitoris or the penis. طيب. And it gives us the anterior Aylin nerve and the perineal branch of the pudendal nerve. Okay, so 3 things. Here's another slide about it. طيب. So S2, S3, S4, it goes out. طيب. So this, we're looking at it from the medial side. طيب. It goes out of the pelvis through the greater sciatic foramen. بتشم هوا, or like it breathes, and then comes back in طيب, into the pelvis through the lesser sciatic foramen. It gives off the inferior rectal, gives off our perineal nerve, or the branch that supplies the perineal muscles, and it gives off the dorsal nerve of the penis. Okay, so in males, dorsal nerve of the penis. In females, dorsal nerve of the clitoris. Okay, and it passes through what? Alcock's canal, we mentioned. Okay. Now, there is something called pudendal block. Now, what is that basically? So whenever they want to have a procedure, طيب, for females, okay, this procedure here, and during childbirth, if there's a complication in the child's head, for example, is too big to come out, or there's a risk that there's going to be a rupture of the vagina or something, basically what they do is that they do a pudendal nerve block, okay, and then they perform something called an episiotomy. There's an episiotomy. They basically cut by scissors the skin here so that they spread it out and they make the opening wider. Okay, so how do they do this pudendal block? They basically we mentioned that the pudendal nerve supplies the whole perineum area, طيب ف they have to like put anesthesia around that nerve, طيب they just have to palpate for the ischial spine, I think, طيب and then they go in with the needle, they put the anesthesia, but one thing that they shouldn't do is pierce the nerve because they can damage it. They just have to put the anesthesia around it and then wait, and then perform the surgery. Okay, and then perform the episiotomy. Okay, here's a revision. طيب, as we mentioned, the right common iliac gives off external and then internal. Now, internal gives off what? Posterior and anterior. Okay, now posterior branch gives off I love steak, iliolumbar, then lateral sacral, and I don't think it's shown here, but superior gluteal. طيب is also given. And then for the anterior branch, we have. Oh, okay. Here for the anterior branch, we have the. Okay. Okay. So superior vesicle here, and then we have the obturator, as you guys can see. طيب. For some reason, the obturator here is coming from the posterior branch, but this is not correct. It's supposed to come from the anterior branch. طيب. And then we have the vaginal artery. This is a female. طيب. Then we have inferior gluteal. You don't really need to know that. طيب. Then we have the internal pudendal artery, the middle rectal artery. طيب. I think this should be clear by now. Now just pause the video for a bit. طيب. Solve for all of these from 1 to 15. Okay. And you'll be good صراحة يعني for all of these models. Okay. 3, 2, 1. Here are the answers. Okay. Here are again the vessels. But صراحة to be honest, this is quite simple. طيب, here we have the aorta, common iliac, and the internal iliac, external iliac. That's it. طيب, there's really not much to it. Okay. So basically, this slide has a bunch of nerves that you guys already took before in other blocks, and I don't think you're going to be tested on them. However, I'll just mention them quickly just to be safe. Okay. Now, here we have the subcostal nerve. Then we have iliohypogastric and ilioinguinal. طيب. Iliohypogastric, ilioinguinal. Then the lateral femoral cutaneous nerve. طيب. Then we have the femoral nerve. You can see how thick it is. طيب. And then we have the genitofemoral. Okay, right here. And then lastly, we have the obturator, which is this straight nerve here in the middle. طيب. Now we're done with the general repro system. Now we're going to move into the male reproductive system, starting off with the dry lab. طيب. First off, you guys took the perineum in the dry lab. And we know that the perineum is divided into two triangles. We have an anal triangle and a urogenital triangle. Here you guys can see on the schematic diagram. There's the anal triangle with the hole for the anus, and then the hole or the hiatus for the urogenital or for the urethra. Okay. Now here's the male perineum. طيب. So I put this picture on purpose because in our final they shocked us with a picture like this, but it was a real human being. طيب. Be prepared for these kind of pictures. And we said it's divided into two triangles. Here at the top we have the urogenital triangle, and then at the bottom we have anal triangle. Okay. Now, what divides them into two triangles is this imaginary line here in the middle. It's between the two ischial tuberosities. طيب. And then anteriorly, the border for the urogenital triangle is the pubic symphysis. Now, why is it anteriorly? Because this picture is the patient is lying on his back and in a lithotomy position. طيب. However, naturally, he's going to be standing up. So anteriorly, it's what? The pubic symphysis. طيب. And towards the side here we have the two ischial tuberosities. طيب, we said that the ramus between the ischium and the pubis is called the ischiopubic ramus. طيب, that's the lateral borders for the urogenital triangle. So laterally we have ischiopubic rami, anteriorly we have pubic symphysis, posteriorly we have the imaginary line between the two ischial tuberosities. Okay? Now, if we go like inwards or compared to the triangle upwards, so into the patient, like into the patient's body, we're going to reach a dead end, which is going to be our levator ani muscle. Okay? And the floor is going to be the perineal membrane, which is covering it here. Okay? Now, here's what it looks like in a coronal section. We have the levator ani muscles. As we said, this is going to be the roof. Okay? And then the floor is the perineal membrane here. طيب. Now, outside, which is not like it's not really clear on the picture. طيب, it's not showing. We have the ischio-anal fossa. طيب, however, I'll keep it for later. Now, I just want you guys to know that we have the deep perineal pouch, superficial perineal pouch. We're going to get into the contents in a bit. طيب, so superficial, deep, these are the two parts of the perineum. Okay? Between them, we have what? The perineal membrane. So, starting off with the superficial perineal pouch, we have the bulbospongiosus muscle, which is right here, طيب, in the middle, because it looks like a bulb. طيب. And then we have ischiocavernosus muscle. Okay, ischiocavernosus. Why? Because it goes from the ischium to the corpus cavernosum. طيب, this part of the penis, which I'm going to explain later. طيب, so from the ischium to the corpus cavernosa, it's called ischiocavernosus muscle. طيب, this is also part of the superficial perineal pouch. Then we have the superficial transverse perineal muscle. This one here. It's transverse and it's in the superficial pouch. So superficial transverse perineal muscle. I think it's quite obvious. Then we have the perineal body, and then we have the pudendal nerve. These are also parts of the superficial perineal pouch. Okay? We also have the external anal sphincter right here. If you guys can see it, number 6. This is the external anal sphincter. And next up, we have the deep perineal pouch. Now, in the deep perineal pouch, we have the membranous urethra. We have the external urethral sphincter. We have the deep transverse perineal muscles. We have the bulbourethral or Cowper's glands. And we have the dorsal neurovascular bundle of the penis. طيب. Now, let me zoom in so that we can see all of that. Can you guys see here? The urethra. طيب. We removed the perineal membrane so that we can see the deep pouch. طيب. We removed it and it's outside here. Okay. So can you guys see the urethra and the external urethral sphincter? And then we have the deep transverse perineal muscle. And this is the, this is peeled from this picture and it's placed here outside. طيب, just so that you guys know what's going on. And we mentioned also our Cowper's gland or the bulbourethral gland over here. And these are the contents for the deep perineal pouch. Okay, these tables here are just for completion's sake. Read them. And now we have the male external genitalia. طيب. So here we have the bladder, then we have the prostate, then we have the urethra coming all the way from the start of from the bladder till the tip of the penis or the glans penis. طيب. Glans penis is the tip of the penis. All right. Then we have corpora cavernosa. Remember when I told you the muscle that goes from the ischium to the corpora cavernosa is called ischio? Where is it? Let me show it to you guys. Ischio cavernosus here. Okay. All right. And then we have corpus spongiosum. Now, what's the point of corpora cavernosa? It basically has an artery in the middle of it, okay, and it fills up with blood for the penis to become erect. Right? Now, if these two corpora cavernosa fill up with blood, okay, and we don't have the corpus spongiosum, your urethra is going to get compressed, okay? And unfortunately, you wouldn't be able to ejaculate and you wouldn't be able to pee. That's why we have the corpus spongiosum to keep the urethra patent or open, okay? And yeah, here we have can you guys see here? Not all of this, it's only this tiny circle here that is the external urethral sphincter. طيب. Is there anything else? I think that's it. طيب. Now for histology. First, we have seminiferous tubules. Okay. Now, how can you tell that these are the seminiferous tubules? These are basically where the sperm come from. Okay. So can you guys see here? It kind of looks like the sperm is budding off of the wall. Like this is the tail. Like when the heads are like towards the wall. Like that's why it's called the germinating epithelium. Like so, if we cut the testes, it's going to be here. Like seminiferous tubules. All right, and this is what they look like. Next, we have the efferent ductules. طيب. So efferent ductules, the identifying point is basically is that they're uneven. I'm going to get into the details later. However, these slides are just to introduce you to the slides, to the histological slides, I mean. Okay. And it has a pseudostratified columnar epithelium with microvilli and cilia. Can you guys see them here? Over here? Yeah. Then we have the epididymis head, okay, or the head of the epididymis, however you guys want to say it. The difference between it and the ductules is basically that it has a tall pseudostratified columnar epithelium with stereocilia, okay? So these are more tall. That's how we can identify them. And they're more even, all right? Then we have the ductus deferens or the vas deferens. Right? This is what carries the sperm outside of the testes, okay? And this is what it looks like. It kind of looks like a flower. I'll show you guys all the identifying points and all the details in a bit. Right. Now, seminiferous tubules. Here we have the testes. It's like a cross section. And then we zoom into it. Right. Can you guys see the sperm cells germinating? So it's called the germinating epithelium. Right. So here in the middle, we have the seminiferous tubules. And then outside, can you guys see these cells on the side here? Right? These are the Leydig interstitial cells, and they produce our testosterone. Okay, so the germinating epithelium or the seminiferous tubules for sperm production, B or the Leydig cells are for testosterone production. You guys should already know this also from physio, right? And then all of this is wrapped around, like wrapped by something called tunica albuginea, which is basically like a capsule surrounding the testes. Okay, now how can you identify this slide? It's basically a stratified germinating epithelium. Okay, and you might have to know the different steps صراحة, but I don't think it's going to be that detailed. But moving from like outside to inwards, we have spermatogonia, then primary spermatocytes here, number 2, the second layer, and then when you move further, there's spermatids, and then lastly there's spermatozoa. Okay. Next we have ductus deferens. طيب. No, we have we have the efferent ductules with the epididymis head. Now, how can you tell the difference between the two? How I like to think about it, in the ductules, طيب, they're kind of like cute and unorganized. You know, they're whimsy. طيب. But the epithelium is kind of irregular. طيب, it's uneven. However, epididymis head, okay, so it's a head. It has to be like straightforward. So that's why the epithelium is even. Okay. And that's how you can differentiate between the two. It's basically these two sections here on the diagram. Next up, we have the efferent ductules, but in detail. طيب, so you have to know all of this, like all of these details. And we said it's a pseudostratified columnar epithelium with microvilli and cilia. Okay. And you have to know the 3 types of cells. Okay, which is cuboidal with microvilli and columnar with cilia. That's why it's what? Uneven. طيب. And short basal stem cells, صراحة you can just know it. Why not? طيب. And there's a thin circular smooth muscle layer, okay, which is صراحة, I'm not sure if you guys can see it, but can you see this thin layer of smooth muscle around it? This is basically it, okay? And the function is the microvilli are there for fluid reabsorption, and the cilia is there to transport the sperm. Okay. Now, if they ask you where can this tissue be found, you can mention that it's between the rete testis and the head of the epididymis. Okay. So first we have the efferent ductules, then we move on to the head of the epididymis. But however, the most important thing is the uneven lumen from alternating cuboidal and columnar cells. Wait. Okay. Now, for the epididymis head, it's also a pseudostratified columnar epithelium. However, this time we have stereocelia. Right? And you mentioned that the difference between this and the previous slide is that this is more even. Okay, so it's tall and even. Now, obviously, pause the video, read the functions and all the different details about it, because it's extremely important. Now, vas deferens. طيب. Now, the vas deferens, the way that I thought of it back then is basically it looks like a clover. Okay? It looks like a flower. And it has a lot of muscles around it, a lot of muscular tissue. So it has longitudinal, inner longitudinal, then middle circular, then outer longitudinal. So LCL. طيب. Of course, you guys know why this looks circular here and why that looks longitudinal. طيب. Yeah, why is it the opposite? Because it's a cross section. طيب. So here circular, then here longitudinal. طيب. So the circular is sandwiched in between. Now, its function is basically ejaculation. طيب. It transports the sperm from the epididymis to the ejaculatory duct. Okay. Now, why do we need the muscles? Because in order for us to transport the sperm, we need what? Peristalsis. Okay. And where can we find it? It's in the spermatic cord. طيب. I think that's it. Seminal vesicle. Okay, now this has a honeycomb-like appearance, so that's why I put the honeycomb here, so that you guys don't forget it. So because the mucosa is basically thrown into folds, that's why it looks like a honeycomb. Okay, I'm not really sure if you guys can see it, but it's called it's given that name basically. So this is the seminal vesicle. طيب. Here we zoomed into the sections, and this is the lumen. And then the cells that we have are columnar secretory. Can you guys see here? Which one is columnar? I think this one looks columnar enough. طيب. These are the secretory cells. And then we have short basal at the bottom. طيب. Now it says that it has lipochrome or lipofuscin, the yellow pigment. However, I don't think you can see it clearly, but here, can you guys see this brown stuff? I think that's what they mean by lipofuscin. Okay. And we can find it in the posterior wall of the urinary bladder. طيب. This is the seminal vesicle. That's its location here. Can you guys see it on the diagram? Now this secretes the majority of the seminal fluid. It says here 70%. Okay, that's its function. And now we have the prostate gland. The prostate gland is different in young and adults, and I'm going to show you the difference in a bit. However, now let's just take the common structure. First, it has the type of tissue is fibromuscular. So if they ask you about the type of tissue, it's fibromuscular. So it has both smooth muscle and connective tissue. It has columnar secretory cells. Can you guys see them here? Because it's a gland at the end of the day, so it has to secrete something. There's the acinus where the fluid or the secretions are being secreted. Okay. So here we have the columnar epithelium, pseudostratified columnar. And I think that's it for prostate gland. It secretes the rest of the seminal fluid. That's its function. Here it is on the model. Can you see? There's the prostate gland. Now, this is important. طيب. How to differentiate between young and old? The only difference is the young doesn't have corpora amylacia. I'm not really sure how they pronounce it, amylacia. However, I'm going to pronounce it as amylacia. Okay, so the corpora amylacia are not present in young. However, in adults, you can see them, and they kind of look like sliced onions. Can you guys see them here? These are the corpora amylacia. All right. However, it's still the same pseudostratified columnar epithelium. It has lamina propria. It has the fibromuscular stroma. Everything. It's the same. The only difference is corpora amylacia, which are basically called prostatic stones. This is just for you to recall. Pause the video, name all of them. All right, here are the answers. Okay, now wet lab. First off, We have the penile layers. So here's just a small mnemonic for you guys to remember it. Skinny doctors buy cold coffee tonight. If you guys are not good with mnemonics, you can totally ditch it. It's fine. Right? So the layers from outside, we have the skin, then we have dartos fascia, buccal fascia, corpora cavernosum, which is the erectile tissue, and then we have corpus spongiosum here surrounding the urethra. Why? To keep the urethra open when the penis is erect. And then lastly, we have tunica albuginea, all right, which is this layer here and here, the yellow layer in this picture. This albuginea translates to white. Okay. Now, can you guys see here? Here we have a deep dorsal vein. Then we have the dorsal artery of the penis. Then we have the dorsal nerve of the penis. Okay. Remember these well. And the order is van from middle to lateral. Both sides. Van. Okay. And then above it, we have superficial dorsal vein, but this is not really important. I just want you to remember these three. طيب. And we mentioned that the thing that makes the penis erect is basically the deep artery dilates and blood rushes into it and it fills the corpus cavernosum. Okay. Now here's what I meant from wet lab. Okay. Deep dorsal vein. Can you guys see the next thing after it is the deep artery. طيب. And the dorsal nerve of the penis, I don't think you can see it. صراحة بس yeah. You can only see the vein and the artery. Now, we have the scrotum. We have a lot of layers for the scrotum. طيب. First, we have the scrotal skin or the dermis. Okay. Then we move on to the dartos muscle or dartos fascia. Okay. A dartos muscle or dartos fascia is also called superficial fascia. Okay. Then we have all of these together. طيب. We call them the external spermatic fascia from outside to inside. Cremaster muscle fascia, internal spermatic fascia, tunica vaginalis, parietal, and we have a visceral layer, okay, which is stuck to the testes itself, and then tunica albuginea, okay. So again, from outside, we have the skin, okay, scrotal skin, then the layer after it, طيب, we have the superficial dartos fascia, or dartos muscle. Now, dartos muscle, basically, when it's really cold, dartos muscle shrinks or like contracts, and it makes the scrotum shrink and pull the testes towards the body. Okay. Cremaster muscle is a muscle that, wait, actually, let's mention first external spermatic fascia. External spermatic fascia is just a layer of fascia. There's nothing much to it. However, cremaster muscle is like a muscle that lines the spermatic cord, right? Now, when that muscle gets activated or like stimulated, right, there's a cremasteric reflex that takes place. And this also raises the testes towards the body. It contracts and raises the testes towards the body. Okay. Then we have internal spermatic fascia and tunica vaginalis, the parietal layer. right? These are all of them together. طيب صراحة they can't separate them in wet lab. So they're stuck together. Then the layer that's stuck to the testes is tunica vaginalis, the visceral layer. Okay. And then lastly, we have tunica albuginea. And can you guys see the epididymis here? This is the testes, and this is the epididymis. طيب. Now, how can you memorize all of these? I have another mnemonic. Some darn Englishman called it the two testes. Okay, so S for skin, D for dartos, English, E for external spermatic fascia. Then we have C, cremaster muscle, I, internal spermatic, then G, tunica vaginalis parietal, 2, tunica vaginalis visceral, and then T, tunica albuginea. Here is another schematic diagram where you can see all the different layers. طيب. And we also need to know the origin for some of them. For dartos muscle, it comes from Camper's and Scarpa's fascia. طيب. I think you guys took these in anatomy. And then external spermatic fascia is from external oblique aponeurosis. طيب. Which external oblique is the abdominal wall muscle. طيب. And the aponeurosis, or the like the fibrous layer of it, forms fascia, which is called the external spermatic fascia. then the cremaster muscle from the internal oblique aponeurosis, and then from the transversalis fascia, we get the internal spermatic fascia, and then both tunica vaginalis are from processus vaginalis. Okay, and you need to know these. You need to know the order and the origin. طيب. Now we have the anal triangle. طيب. First off, you need to orient yourself. This is the patient lying on his stomach. So this is behind, basically. طيب. Here, as you guys can see, we have a deep hole. طيب. Now this is the ischio-anal fossa. Why is it called ischio-anal fossa? Because here we have the ischium to the side, and then here we have the anus or the rectum. طيب. So here between them, ischio-anal fossa. Fossa is basically like an opening. طيب. Now here, if you guys can see this muscle, صراحة I hate wet lab pictures because you really can't see anything. I mean, you just have to like convince yourself when you're seeing things. However, this right here is the obturator internus muscle. طيب. And this is the ischium. طيب. So obturator internus. And then we said that something passes here. Remember? The pudendal nerve. طيب. So here we have the pudendal nerve. It gives off a branch here, which is the inferior rectal because it's going to the rectum, as you guys can see. طيب. Towards the anus, sorry. And this is the medial ani muscle. Levator ani, sorry. It's the medial wall. طيب. So medially we have the levator ani. And then remember, we mentioned that the pudendal nerve goes through something called Alcock's canal. طيب. This is Alcock's canal here, which is deep to the obturator fascia, covering the obturator internus muscle. طيب. Let me zoom in here so that you guys can see. All right, so as I mentioned, the pudendal nerve, طيب, it goes into Alcock's canal. As you guys can see, this is the fascia covering the obturator internus. طيب, here's where you can find the Alcock's canal. There's also the pudendal vein and artery that pass with it, but الصراحة they only care about the nerve. طيب. So here, internal pudendal artery, internal pudendal vein. Okay, all of these three pass through the Alcock's canal. Okay, here's another view. Oh, and the patient's head is over there. His feet is towards that side, towards the right. So that is the medial side. This is the lateral side. So this is the ischium, obturator internus. Here, this nerve is this is not the pudendal nerve. This is the inferior rectal nerve coming out of the pudendal nerve. Right? So the pudendal nerve is coming down. It's going to give the branch here that we mentioned earlier, which is the inferior rectal, because it's going towards the anus. Then, if you guys can see, there's the hole I mentioned earlier. There's the ischio-anal fossa. طيب. Now, you need to know the borders of the ischio-anal fossa. So laterally, طيب, here I want you guys to follow with the text. طيب. Laterally, we have the ischium and the obturator internus. طيب. So here, this side is what? The obturator internus with the ischium, laterally. Then, medially, as we said, levator ani. Okay. Also, the external anal sphincter, but صراحة is really not that important, but just know it because why not? طيب. Then, posteriorly, we have the sacrotuberous ligament. طيب. You can't see it, but posteriorly, طيب, we have the sacrotuberous ligament. That's the, what's it called? The posterior boundary. And then the floor, طيب. The floor is basically your perineal skin, صح? Because the whole thing is shaped like a tent. طيب. So it's like a tent. طيب. At the bottom, we have can you guys see me? Wait. All right. So at the bottom, we said the floor is the what? The skin. طيب. Then we said that the medial side is made by the levator ani. The lateral side is made by the obturator internus muscle and the ischium. طيب. Then posteriorly, from behind, we have the sacrotuberous ligament. طيب. And what else is left? Okay, the meeting point at the top is basically the obturator internus fascia, because we said that laterally it's obturator internus. طيب. And we said medially there's levator ani. They're going to meet. طيب. So that meeting point is your roof. Okay? I think there's a picture here at the back somewhere. Let me just find it. Okay. Okay, yeah, here. Right. So if you guys like, if this picture is not complete, however, here the elevator ana is going to stop at a point, and at that point, it's going to meet the obturator internus. That meeting point is the roof. Okay. I hope it's all clear now. All right. And I think that's it for the male reproductive system. By the way, the SQ anal fossa and like the last wet lab is for both. However, I just didn't know where to put it, so I just added it to the male section. Okay. Now for the female reproductive system, we're gonna start off with dry lab. Again, we have the perineum. Okay. As we mentioned, there's a lithotomy position. Here we have the urogenital triangle, the borders, pubic symphysis anteriorly. Then we have the posteriorly, we have the imaginary line between the ischial tuberosities. Then we have the ischial pubic rami on the sides. Right? Then we also have the anal triangle at the bottom. Now, can you guys see here? Can you like see the urogenital triangle, how it is in females, and the anal triangle? All right. There's another picture without the muscles, pubic symphysis, ischial pubic rami, and the imaginary line between the ischial tuberosities. Next. All right. Now, again, the females have a deep perineal pouch and a transverse perineal pouch, superficial perineal pouch, sorry. Now, in the females, the superficial perineal pouch is exactly the same as the males. However, we have two important extra structures. One is the clitoris, okay, which is the erectile tissue in the female's genitalia. Here, if you guys can see it, this is the clitoris. And then we have Bartholin's gland. Is it not mentioned here? Okay, it's not shown here. However, we also have Bartholin's gland. I think it's on the model. Wait, let me go back. Yeah. Can you guys see this? This is the Bartholin's gland. Okay. So this is for identification. Again, as we mentioned, this is the ischio cavernosus. Now, remember, we said over there in the penis that it was the corpus cavernosum. طيب. Here, we also have corpus cavernosum. However, it's really tiny. طيب. That's why we also have the ischio cavernosus muscle that attaches to it. Okay. And then we have the clitoris. Then the same bulbous spongiosus, ischio cavernosus, the superficial transverse muscle, everything is the same. طيب. And then the deep, we have, again, it's the same, the membranous urethra, the sphincter urethra muscle, the deep transverse perineal muscle, the internal pudendal vessels, everything. However, the additional thing is the, obviously, vagina. And we also have compressor urethra in females. طيب. Compressor urethra is also here. I forgot to write it here. I'm going to add it later. So remember compressor urethra. So here's the model or the drawing. The urethra is here in the middle. Then we have sphincter urethra vaginalis. Then we have compressor urethra. Sphincter urethra vaginalis is the same as the sphincter urethra, by the way. And these are the components of the deep perineal pouch. This structure is also the same. The only difference is compressor urethra, as I mentioned. Now, the external genitalia. First, we have mons pubis. Mons pubis is basically the most external part, and it usually has the hair on it. Then we have labia majora. Labia majora also has some hair, and then labia minora is the one without hair. Then we have clitoris, as we mentioned earlier. And then we have the external urethral orifice. So this is the urethra here. External urethral orifice, and this is the vaginal orifice. Okay. Now, this whole thing is called the vestibule. طيب. Remember the Bartholin's gland? طيب. They're also called the vestibular glands because they're found in the vestibule. طيب. Now, they're like deep into the structure, so you can't see them. However, they open into this tiny hole. I'm not sure you can see it, but yeah, they open into these. And I think that's it. There's the anus, of course. And yeah. Now, this is the vestibule, as we mentioned. طيب. It has what? This is the vestibular gland. طيب. Here, vestibular gland is the vestibular bulb. You need to know all of these. طيب. Now, the vestibular gland opens into the what? These openings here, tiny openings. So I don't think they're going to ask you about them because they're really tiny and you can't see them. However, you might be asked about Bartholin's gland. طيب. And this is the vaginal orifice. Everything is still the same. Okay, so vestibule, mons pubis, clitoris, labia minora, labia majora. Yeah, that's it. Here's a diagram. طيب. Oh, remember this thing about Bartholin's glands is that sometimes they might get infected. طيب. And they can form into Bartholin cysts. طيب. And they just treat it by draining it. حرفيا that's it. طيب. And they just wanted you guys to know them. To know that like piece of information. Here is the vestibular bulb, as we mentioned. This is the Bartholin gland. So vestibular bulb, towards the end of it, we have the gland itself. Then we have the vaginal orifice, external urethral orifice. Next up, we have another model. طيب. This is everything all together. These are the pelvic diaphragm muscles. طيب. Then here we have the urogenital triangle. Then we have the vestibular bulb. We have the Bartholin's gland. طيب. This is also the perineal body, which we mentioned. طيب. What else? Bulbospongiosis. Ischiocavernosus, can you see it? It's the one going laterally. طيب. And this is the perineal membrane, which splits the superficial and deep. And I think that's it. Make sure to revise these labels very well. And then here is another model. طيب. Now I want you guys to know these very well. The anterior fornix, طيب, and the posterior fornix, which are kind of like grooves, or I don't know, they're like dead ends, طيب, around the uterus. طيب. Now the posterior fornix is important in something called coldocentesis. It's basically when we know that this is the pouch of Douglas, طيب, from previous blocks. طيب. Now if there's fluid that builds up here or blood and they need to drain it, how can they reach into that area is they go through the vagina and they poke through the posterior fornix to get into the pouch of Douglas. They drain it out, and that is basically called a coldocentesis. Okay. And lastly, we have a hysterosalpine geography. Okay. Hyster means the uterus. Salpinge is the oviduct or fallopian tubes. طيب. Now, hysterosalpine geography. Wait, did I mention here that this is the uterus? Okay, you have to know that. طيب. It's lying above the bladder. Okay. Yeah. So the different parts are from the top, we have the fundus, okay, of the uterus. Then we have the uterus itself, or the uterine cavity. طيب. Then we have the isthmus of the uterus, طيب, which is like a narrowing. And then this part is not important, صراحة, the palmate folds. And then we have the cervix. طيب. It's dilated because the tube itself is inside, like the device that's responsible for this hysterosalpine geography. طيب. Then going to the fallopian tubes, we have this here, the fallopian tube, or the what's it called? Fallopian tube or oviduct. طيب. However you guys want to call it. It's also here mentioned as uterine tube. So it has many names. طيب. However, most commonly it's fallopian tubes. طيب. And this is the isthmus. As we mentioned, isthmus is a narrowing. طيب. For this narrow section is the isthmus. And then 7 is the ampulla. What does that mean? Ampulla means it's getting wider. طيب. So the ampulla of the uterine tube here is the wider section. And then here, towards the end of it, طيب we have the infundibulum. Okay, the infundibulum of the uh, oviduct. Then what else do we have? Here it's pointing towards the pectinate line, remember, that we mentioned earlier in the pelvis. And I think that's it. Now for histology, this is the ovary. Okay. Um, this is not supposed to be here. Okay. I just want you guys to know, and this is the ovary. Okay, we have oogenesis happening over here. And once the egg leaves the ovary, it leaves something behind, which is called the corpus luteum, which later then secretes progesterone. You know your physiology, I hope. Right? However, it's not, this is a pig ovary. It's not a human ovary. They just wanted you guys to see what it looks like. Right? Now this is what a human ovary looks like. And we know that from previous blocks that any solid organ has a cortex and a medulla. طيب. Just like the kidney, just like the brain, they all have a cortex and a medulla. طيب. So the ovary is a solid organ, so it has medulla here in the middle and then cortex. Can you guys see in the cortex these bubbles or circles? This is basically oogenesis taking place. All right. So here we have primordial follicles, which is the very first stage, right? And then it progresses onto primary oocyte, and it has a primordial follicle has a primary oocyte in it, right? Remember, you have to remember, it's 2n, and then after multiple divisions, it becomes into n. You have to know it, but I think that's from physiology, right? And yeah, so here we have the primordial follicles with primary oocytes. طيب, simple and easy. طيب, now, can you guys tell here that this is simple squamous epithelium? Can you guys see how flat it is? Then we have the primary oocyte in the middle. And here we have stromal cells. That's it. Stroma is connective tissue. طيب, there is no zona pellucida. طيب. Now, how you can identify the early primary follicle with a primary oocyte. It's not primordial, it's early primary. Okay, it basically looks like an eyeball. Can you guys see? This is the black part of the eyeball. This is the lens, and then the white part. طيب. This is just for you to identify. طبعا you can't say that as an answer. طيب. And then it grows into a late primary follicle. طيب. Now the follicle here at 1, can you guys see here? Wait, let me zoom in actually. طيب. Can you guys see the epithelium? Can you see how cuboidal it is? طيب. And then we have the zona pellucida here. Can you guys see it? All right. And then we have the oocyte itself, which is the egg, and the nucleus in the middle. And then, of course, outside we have the stromal cells. Then, in the late primary, we still have the follicular cells are actually called now granulosa cells. طيب. So here, can you guys see the granulosa cells? And this is the zona pellucida still surrounding it, this circle. And then we move inwards. This is our primary oocyte. All right. And then the nucleus in the middle. And then around it is the stromal cells. The stromal cells here are called theca cells. Okay. Now we progress into secondary follicle. In secondary follicle, we have a secondary oocyte, which is now 1n. Right? So here was 2n, 2n. Now it's 1n. Okay. Once we zoom in, we can see here. Can you guys see the granulosa cells? طيب. Now they become more stratified. They're still cuboidal, but they become more stratified. One additional structure that is added here in secondary follicle is the antrum. Right? So remember, we mentioned that the primary follicles look like an eyeball. Basically, imagine the eye stretches to become like a human eye. Right? So here you can see the white parts, and here's the lens in the middle. Right? That's again for you to identify it. Right? So this is the antrum. Right? It's starting to develop. Right? And then outside, the stromal cells that turn into theca are still theca folliculi cells. طيب. And I think that's it. The follicle here is stratified. Don't forget that. Stratified cuboidal granulosa cells. طيب. Now we reached tertiary or Graafian follicle, which is the mature ovum. Can you guys see how the antrum is large and like uniform here? And one more thing, we pushed the oocyte to the side. طيب. So one, let's start from outside. We have what? We have the membrana granulosa, طيب, which is the wall basically. And then we have here at two, can you guys see this? This is called cumulus oophoros. Now, what is that? It's basically the thing that is carrying the oocyte. طيب, it's like a group of cells. طيب, they're also granulosa cells. Then around it, we have corona radiata. Corona radiata. Corona basically means crown. طيب. So it's basically like sitting like a crown on top of the oocytes. طيب. So corona radiata, it's still granulosa cells. They're all granulosa cells. All right. Now four, can you guys see here this pink thick layer around it? This is our zona pellucida. And then five is the oocyte. Okay. And here we have the antrum, number 10. And then we still have granulosa cells. Remember here, in one we said granulosa cell, membrana granulosa. It goes around all the way, طيب, surrounding the whole follicle. طيب. Then we have theca interna, طيب, then theca externa. These are the stromal cells, theca interna, theca externa. Here, there's a blood vessel. صراحة, like, I really hope they don't ask you about this because there's no way you can see it. طيب. However, this thin line is blood vessel. طيب. And that's it for Graafian follicles. A corpus luteum now. After the Graafian follicle has ruptured and the oocyte left, we're left with the corpus luteum. طيب. So here I mentioned the steps: ovulation, the follicle collapse, antrum replaced by this fibrin clot. طيب. And this fibrin clot turns into collagen. طيب, later. However, for now, we're at the corpus luteum stage, which is also called the yellow body. Now, what does this do? It secretes what? Progesterone, if you guys remember from physiology. طيب. Now, the three structures that you guys have to know. One here, can you guys see? These are the granulosa cells. طيب. Granulosa lutein cells. Okay. And then two, these dark basophilic cells are your theca lutein cells, not granulosa, theca lutein. طيب. And then three is blood vessels. طيب. In the corpus luteum. So theca interna cells turned into theca lutein, granulosa cells turned into granulosa lutein, and the blood vessels in the theca layer in granulosa are still there. It just becomes more vascular. طيب. And yeah, we mentioned that it turns into a gland and it's for progesterone secretion. Lastly, it turns into collagen or corpus albicans. Again, albicans means white and collagen, white. طيب. And here is the follicular cavity, which used to be the oocyte. طيب. Now it's replaced by collagen, as we mentioned. And then surrounding it, we have the collagen again, which used to be the corpus luteum. طيب. Then here we have ovarian stroma, which are just stromal cells, supporting cells. This, of course, can't fertilize, and it's just a piece of collagen, basically. We just have to identify it. Then we have fallopian tubes. Now, how can you identify these? To me, they look like red cabbage, if you guys can see it. طيب. So red cabbage, fallopian tubes. طيب. Obviously, it has a mucosa, which is from simple columnar. Can you guys see? Simple columnar. All right. And then lamina propria here, right below it, of connective tissue. And then we also have ciliated columnar epithelium cells. طيب. Because they basically brush the egg to move it. طيب. So we have cilia. And the non-ciliated ones, you really can't tell صراحة the difference, but can you guys see here? Like at 4, it's smooth. طيب when at 3, can you see this? It looks kind of like a brush. So this is the ciliated one, this is the non-ciliated one. The difference between them, 3 is responsible for the ciliated one is responsible for moving the ovum. 4 is for secreting substances to lubricate the oviduct itself. They're also called peg cells. طيب. And then can you guys see this? This is blood basically. So it's an endothelium of a capillary. Okay. Um, oh, and also one last thing I'd like to mention, that here the muscular layer is circular and then longitudinal. Okay, so circular, longitudinal, not 3. In males, in the vas deferens, we had LCL. Here it's just C and L. Okay, from inside to outside, CL. And then outside you have adventitia. طيب. Adventitia, which is called mesosalpinx. Okay. Now, the uterus, طيب, the endometrial gland. These are two different phases. We're going to get into the details later. However, the difference between them, in proliferative phase, okay, you can think of it as like, because it's endometrial glands in a proliferative phase, so they're multiplying. So think of it as bubbles like joining together to make a gland, or acini coming together to make a gland. And in secretory phase, okay, in Arabic, basically, knives are called sikkin. طيب? So sikkin. Okay. And can you guys see it kind of looks like knives, like cuts made by knives. Okay. So this is the secretory phase. Just remember it. طيب. Proliferative phase are these circles. Okay. Now, when we zoom into the secretory phase, we need to identify 3 things first. One, which is the endometrium here. Then the layer of muscle, myometrium. Okay. And then lastly here outside, we have there's supposed to be peritoneum, but it's missing from the slide. Right? Now, obviously, we said that this is endometrium. For anything like on this side is going to be the lumen. Here. Basically here, we have the lumen of the uterine cavity. Then, number 2, we can see endometrial glands. Can you guys see them? The ones that proliferated earlier. Right? And then here, this is stroma, just supportive tissue. And 4, the arteries in a secretory phase become spiral. Right? I'm not sure how you can like identify it in histo slide, but I want you to keep that at the back of your mind. It's spiral. Right? And in the slides, they mentioned that this has a corkscrew appearance. I don't know what they mean by that, but you have to know it. We'll also pause the video and read this at the bottom and make sure you understand it well. Right. Now, endocervix. Endocervix is basically the upper portion of the cervix. طيب. Now, upper portion of the cervix, طيب, at the end we have an X. طيب. You can identify it by the upper half of the X, طيب, which is here. Endocervix. Okay. Now, the layers are this is the lumen of the cervix, and then we have endometrium, and then the muscles, myometrium, and then the cervical gland. Okay. Can you guys see it? Okay, these are glands. Here also, you can see that it's a branching gland. Okay. And you have to know that it's simple tubular. Right? And what do they secrete? They secrete mucus to lubricate the cervix. Okay. So the endocervix secretes. However, the other portion of the cervix, the ectocervix, doesn't secrete. Okay. Yeah, basically that's it. It has a simple columnar epithelium. Don't forget that. طيب, is there anything else? I think that's it. And lastly, the vagina or ectocervix. طيب, ectocervix and vagina, they have the same histology, histological structure. طيب. So one, we have mucosa, which is thrown into folds. We call them rugae. طيب. And then 2, we have the muscularis layer. Again, circular and longitudinal. And then outside here, we have the adventitia. طيب. Now, this basically connects the internal reproductive organs with the external reproductive organs. Okay? And that's mostly it. There's not much to it, صراحة. It's part of the birth canal, of course, like the entire thing. And as I mentioned earlier, you can't see glands. Here, it's stratified squamous epithelium. Okay?
Hi guys, once again, I'm going to be talking about the histology of the mammary gland and the placenta, and I'm going to be covering some concepts that you guys took in your female reproductive system in the wet lab. So for the histology, this was given by Dr. Annie, and Dr. Annie, I think she likes to repeat her questions, so please focus on what I'm going to say. I'm going to tell you exactly what's going to come, inshallah. She wouldn't get anything else. So the mammary gland or the breast is like it's a gland and it has things called TDLUs. What are TDLUs? TDLUs are terminal duct lobular unit, and this is the structural and functional unit of the breast. You know how we say that the kidney, the functional unit is the nephron? Same thing here. The TDLU is the functional and structural unit of the breast or the mammary gland. And if you want to know if this mammary gland is active or it has a lot of if it's active, you see the ratio of the TDLU to the stroma, or like the cells that are not TDLU. And let me show you how that looks like. As you can see here, these are the TDLUs, these clumps, circles. And what is all of this pink? It's the stroma, or like the fibrous tissue. Just the pink cells that are just stroma, they have no function. The TDLUs are the functional and structural units of the breast, okay? فthese are TDLUs, okay? And here, where are the TDLUs? These purple ones. Look how many there are. So what can we say? Is this active or is this active? Is this active? Yes, it is. Because this has a lot of TDLUs. And what do you mean by active? It's lactating. Because these TDLUs, they produce and secrete milk, okay? These the units, the lobular units, and there's so many of them here. You can barely see any pink, you can barely see any stroma. But here it's inactive or resting breast, and these TDLUs, they are there, they exist, but they're like much less, and you can see a lot of pink, a lot of stroma. Okay, here I labeled them TDLU, and this is a duct, this is another duct, and the pink tissue is stroma, it's connective tissue, collagen, fibroblasts, and the white circles here, they're fat, because the breast has a lot of fat tissue. And here TDLU and stroma is pink, there's a lot of TDLUs compared to stroma. Okay, moving on. This is a very important thing to know, the terminology. Ductules are small ducts in the TDLUs, inside the TDLUs. And what lines them? Simple cuboidal. هلا I'll show you pictures. For the ducts, they're larger ducts and they're outside the TDLUs, okay? And they're stratified cuboidal. So look at these pictures. What is this? Is this simple or stratified? This is simple. So what do you think this is? This is a small duct in the TDLU, okay? Not duct, sorry, ductule. This is a small ductule. A small duct, yeah, it's a small duct which is called ductule in the TDLU, inside the functional structural unit of the breast, and it's simple cuboidal. Okay, what is this? Is this simple? No, this is definitely not simple. This is a large duct, and what is this? Also a large duct, and it's very stratified. What was I saying? Yeah, ductule in TDLU, and these are like big ducts because they're stratified. Okay, moving on. What did we say this is? This is a lactating breast, and the lactating breast, the TDLUs, they're more prominent. You have a lot of TDLUs compared to the stroma. And when you zoom into the TDLUs, you can see here, they're ductules. Look, they're simple cells. And I forgot to mention something here, but do you see these arrows? They're pointing at something called myoepithelial cells. They're just muscle cells, and they're the ones that help eject the milk. Now we're gonna see, there's milk inside. So these are ductules in TDLUs because we zoomed into the ductules. And why are you saying it's ductule, not a duct? Because it's simple. It's simple columnar. Columnar or cuboidal? Cuboidal, sorry, cuboidal cells. Simple cuboidal cells. And the inside of them you have milk. If they get you this picture, and you're looking at a ductule, not a duct, it's simple cuboidal, and it's part of the duct, the TDLU. And these areas are myoepithelial cells, and oxytocin triggers the contraction of these cells. So when oxytocin is increased in your body, that means, for example, the baby's crying or you want to feed the baby. So it helps in the contraction of the cells, and it releases the milk. Okay, this is another picture that Dr. Annie had. I'm not sure how important this is, but this is just saying oh, this is the resting TDLU and this is the lactating breast. This is the lactating. Look how many TDLUs there are compared to this. This has a lot of stromal cells. Look, there's a lot of stromal cells. And this one there's a lot of TDLUs, okay? And the reason why in a resting breast the TDLUs are not as prominent because the acini are very poorly developed. There is less acini. And here there's a lot of acini and they're filled with milk. Okay, moving on to the placenta. The placenta, the one thing that's I saw a picture on this in every single past. But please know this. What is this side? Okay, this is the placenta, zoomed out. This side is the maternal side. This is the maternal side, and this is where the fetus would be. Okay, but this is the fetal side. So this is the maternal side, or called decidua bacillus. This is gonna come, I saw this question everywhere, but a decidual bacillus, okay, this is the mother's side, and it looks very pink, very eosinophilic, and it's kind of like, pointing out to nothing, because this is where the placenta ends, and this is where the mother would get like the nutrients and the blood to the baby. And what is this, all of this? This is all called the chorion frondosum, but if you were to specifically talk about certain things, these are villi, okay? These are villi in the frondosum, the chorion frondosum, okay? These are villi. And inside the villi, you have the baby's blood, okay? You have the fetal blood, the baby's blood. And in the like indentations here, which is not the villi, it's not inside the villi, you have the maternal blood, okay? Here in the intervillous space. Okay, so just know this. This is the maternal placenta, and this is the maternal side, and this is the placenta, this is the fetal side. Okay, what is this? What do you think this is? It looks like this, صح? It's more pink, a lot of cells. They look a bit like enlarged. This is the decidual bacillus. This is the maternal side of the placenta, and it's formed from the endometrium. And the endometrium, when the mother gets like pregnant, it forms the placenta. So it's pregnant endometrial stromal cells that form the decidual bacillus, which is the maternal side of the placenta. And what is this? This looks like a villi. As you can see here, this is what's it called? The chorionic villi. And the entire thing is called the chorionic frondosum. But just specifically this is called the villi, okay? And inside the villi, what can you see these like in red? What is this in red? Number 4. This is blood. What is this? Is this the maternal blood? No, this is the fetal blood because it's inside the villi. As you can see here, number 1, it's the maternal blood, okay? What is number 2? Number 2 is something called syncytial trophoblast cells, okay? It lines the villi and it lines it all, okay? But some clusters here, you can find some clusters. These are called syncytial knots, okay? Number 4 is, what did I say? The baby's blood, the capillaries or the fetal blood. And yeah, that's what you have to know. And no, lining the villi is their cells called syncytial trophoblast cells, and inside the villi it's the baby's blood, the fetal blood. And here in 4 you can see the capillaries or the red blood cells, the blood that's for the baby, because they don't mix. The maternal and the fetal blood, they don't mix. And outside is the maternal blood, and then it diffuses in. Now we're going to talk about how it diffuses in. And then these are syncytial knots. But what's the most important thing? The syncytial trophoblast cells, because they line the chorionic villi. Okay? So as I said, there's going to be exchange from the mother's blood to the baby's blood. They don't mix. There's just exchange من برا لبرا, okay? But outside is the maternal blood, okay? You see here, they're pointing at maternal blood. And inside you have the fetal blood. So how does this exchange happen? From mother to baby. I'm going to talk about from mother to baby. And this is the blood, okay? You see this blood, but it wants to go inside. How would it go inside? Follow the red arrow. Now, the first, thing that it has to pass by is, what did we say? The syncytial trophoblast cells. Syncytial trophoblasts, okay? And this is the first layer it passes by. As it's going in, it's going to reach something called a fused basement membrane. This fused basement membrane is the syncytial trophoblast and the capillaries, the endothelium of umbilical capillaries, so the blood basically. And then as it's going in, it's going to exit, and it's going to reach the capillaries. But it's 3 layers: syncytial trophoblast, a basement membrane that's composed of the syncytial trophoblast and the umbilical capillary, and the third thing that has to pass by is the umbilical capillary itself. Okay, this is how it diffuses, and from outside to inside, it's similar. And if مثلا the baby wants to secrete waste, okay. cornice. I saw it in your manuals, and it's something important, and it's what attaches the uterus to the fallopian tube. The fallopian tube has the what's it called? Intrauterine aspect. It's also written in this picture, but just know it starts from the inside, and then the first part is the isthmus, and then the ampulla, infundibulum, and fimbriae. The fimbriae is what, يعني, when the ovary releases an egg, the fimbriae they take it. This is how they have. This is why they have like these what's it called, like hair-like structures, but it's not attached to the ovary. It's not directly attached. The ovary is like kind of floating. Isthmus, ampulla, infundibulum, and fimbriae. Okay, the fimbriae is the last part of the fallopian tube. Okay, here is the picture that would kind of show you. I hope they get you something clear. This is the picture that I found, that you guys had. This is the uterus, okay, and this is the first part of the fallopian tube. Who it's coming out is the isthmus, and then the ampulla, and then it's going, and it's this is the infundibulum, and this is the fimbriae. Look how it's like hair-like structures. This is the fimbriae. This is the way the fallopian tube passes. This is the ovary. It's not directly related or not related, attached to the fimbriae. Okay. Oh, intramural part. Yeah, that's what I was referring to. The intramural part of the fallopian tube. It's like as soon as it leaves the uterus, and it's kind of inside the uterus. Okay. Okay, moving on. This is very important. The ligaments of the uterus. So these ligaments are very important to hold certain structures in place. Okay. So the first ligament is the broad ligament. The broad ligament is the biggest ligament you have, and it's a fold, fold from the peritoneum. And this specific fold forms three things: mesosalpinx, salpinx, sorry, mesovarium, and mesometrium. The mesosalpinx is where is it? It's right here. It's related to the fallopian tube. The mesovarium is related to the ovaries, and the mesometrium is the remaining part, which is all of this, all this yellow structure. Here on top, the mesosalpinx is related to the fallopian tube, and salpinx is another, I don't know what language, maybe Greek, is fallopian tube. It's related to the fallopian tube, and the mesovarium is related to the ovary. It lines the ovaries, and the mesometrium is the rest of it, يعني. So this broad ligament encloses the uterus, fallopian tubes, ovaries, ureters, the round ligament of the uterus, and the ovarian ligament. And we'll talk about these later. What else? What did I want to say? Yeah, the broad ligament is like anterior to these structures. Yeah, مثلا the ovary would be behind the broad ligament. Yeah, the broad ligament covers everything. Okay, and this separates the anterior from the posterior side of the what's it called? This part of your body. Okay, what about the round ligament? The round ligament is a ligament that goes from the uterus to the labia majora. And one important thing that you guys have to remember is that it passes through the inguinal canal. Okay? This is, whenever I searched about this to know what it exactly does, it's related to pregnancy. Okay? Like, when you're pregnant, this round ligament stretches, it allows for the uterus to stretch and to keep it in place. Yani, it's from the uterus to the labia majora, and it passes through the inguinal canal. And wait, I forgot to mention here. There's the ligament of the ovary, the ovarian ligament. It's what connects the ovary, because I told you the ovary is floating and it's not connected to the fallopian tube. It's what connects the ovary to the uterus. It's the ovarian ligament. And the ovarian ligament and the round ligament are from, I don't know if you guys took this, but I taught in a past question, but it's from in fetal life, it was something called the gubernaculum. So it's a remnant of that, okay? Just know this. These are the ligaments once again. You have here the round ligament. This is the one that passes through the inguinal canal and goes to the labia majora. You have the broad ligament, which is basically the majority, the one that lines everything. And you have the ovarian ligament. This is the ovary, and it connects the ovary to the uterus. Okay, the suspensory ligament of ovary. I don't know if you guys took this, but just it's a ligament that's attached to the ovary. This is the uterus. You have the uterus here, and then you have number two is the fallopian tube. As you can see, it's leaving the uterus, and it's kind of like thick. It's not a ligament because the ligament would be like smaller. This is the fallopian tube, and then this is the round ligament. Look how tiny it is. It goes to the labia majora. You can't really see how it's going here, but what I would know from this picture is this is the uterus. This is the broad ligament. If they're gonna get you something, it's gonna be this number 6. This is the round ligament of the uterus, and number 4 is the round ligament of the ovary, and number 3 is the ovary itself. Okay, this is another picture. Number 1 is the bladder. This is يعني the bladder, as you know, the bladder is what's it called? On top of the uterus, okay? It's on top of it. This is the uterus, number two. No, yeah, uterus. And then number three is the fallopian tube, and number four is the broad ligament. The broad ligament, I don't think they're gonna take a picture that's unclear like this. But the broad ligament is the one that covers the entire uterus. Okay, for the arterial supply of the uterus, you have the ovarian artery, which supplies the ovary, and you have the uterine artery and the vaginal arteries, which come from the internal iliac artery. I don't know if they're going to ask you about this, but it's worth knowing that the uterine artery and the vaginal artery come from the internal iliac artery. Okay? This is a very, very important concept. If they were to ask you about something, they're going to ask you about this, which is something called water under the bridge. So what does this mean? Water, they're referring to the ureters, okay? And the bridge is just the artery, and okay? And as you can see here, this is a uterus. And number three, we said water under the bridge. So under the bridge, under number three is the water, which is what? The ureters, the right ureter, okay? And number three is the uterine artery. So it's very important in surgeries. Sometimes when they ligate this, they can accidentally ligate the ureters, and it could يعني, lead to a lot of complications. But it's very important to know that, or if they get you this picture, to know what's lying underneath is the ureter, and what's above it is the artery, the uterine artery, and the ureter lies under it, so water under the bridge. And I think they might ask you about this very high yield. Okay, these are just pictures I found. I'm gonna add them just for inclusion purposes, يعني. This is the uterus, and this is the bladder. Okay. Um, Something that's very important here is the posterior fornix, which is right here, yeah, number 11. Okay. Why is this important? Because here you have the Douglas pouch, and sometimes a lot of fluid accumulates here, and they could reach the Douglas pouch from going يعني, up هيك through the vaginal canal. They go up and they reach it. Okay. But I think that's, if they were to ask you about something, it's going to be about this, or this is the uterus, this is the. Okay, guys, I said before that the uterus is under the bladder, but the bladder is under the uterus. Yeah, that's the most important thing from this picture. I don't think they're gonna get you this because it's not very high yield. But if they were to get you something, they're gonna tell you about this pouch of Douglas and its clinical significance. Like the fluid accumulates there. Okay. Okay, this marks the end of our PAL. Thank you guys so much for listening and thank you for your patience. I know it was a very long PAL. Inshallah, you're going to do amazing on your exams.
This was a recorded file. If you guys have any questions at all, feel free to reach out to us at any time. Our numbers are on the first slide. Thank you guys so much for tuning in and good luck.
Yeah, don't forget to fill the feedback form. Thank you guys.
Yeah.
Bye.